Good afternoon, respected doctors. I am Nanda Zuvatkar from Zydus, and I consider it as my privilege to welcome you all to this 13th Best of DDW at the AIG Hospitals, Hyderabad. This tradition of disseminating clinically relevant academics has continued for 13 years only and only because of your genuine interest in science and, of course, your affection for Zydus. We at Zydus stay committed to partnering with such initiatives that ultimately help in improving the patient outcomes. For us, we associated with hospitals and the best of DDW for the last 13 years. Of course, the best of DDW have been even this year, ensure that we get best for this activity, but clinically relevant for gastroenterologists who attends this program. Without much ado, let me invite Randir.
First session, which is going to be on pancreas. As usual, the first session is 40 minutes by national speaker, followed by a 30-minute discussion. So Dr. Nalini, I think it's very early in the morning for him. It's like 5:30 or something, but he's awake there for us and he's going to talk pancreas module. Nalini is, of course, everybody here knows him very well. Worked in Wisconsin, had a brilliant career. Recently has become the AIG Distinguished Educator. Also was given the International Leadership Award from AIG. He was a Master Endoscopist from AIG. So a lot of hats he wears. Nalini, thank you for coming this early morning. We have a very eminent panel and request the panel to come over. We start with Naresh Bhatt. Naresh is from Bangalore. Then Nilay Mehta from Hyderabad. Rajiv Mehta from Surat. Rupjyoti Talukdar from AIG. Mohan Ramchandani and Surendra Rana. Surendra. So, Nalini, the panelists are all ready and we'll start first with your talk.
Good morning, everyone. Are you able to hear me?
We can hear you, Nalini, and we can also see you well.
All right,
the panel is all here, led by Naresh.
Thank you. Good morning, good evening, everyone. It is an honor and pleasure to be here. I would like to thank Dr. Reddy, the course directors, and the organizers. It's so great to see virtually all my friends and colleagues who are moderating the session. In the next 40 minutes, I would like to give you a bird's eye view of all the recent developments in pancreas at DDW. Right. Is everybody able to see the slides?
Oh, yes, Nalini.
Okay, great. So what I did, as usual, is that I've divided the topics into acute pancreatitis, chronic pancreatitis, pancreatic cysts, pancreatic cancers, translational medicine, and pancreas. I will not be going into great detail but endoscopically, as Indian gastroenterologists, we are doing extremely well. So I think it's time for us to get to do some translational research as well. So I wanted to perk some interest in this area as well. And I will briefly touch on artificial intelligence, how it's going to affect our lives, because no meeting these days is done without talking about it. In acute pancreatitis, we'll be talking about the role of fluids. We all know that fluids are a quintessential part of management. What kind of fluids are helpful? Is there a way we can triage patients with acute pancreatitis safely and discharge them home? And the role of ERCP in recurrent acute pancreatitis. In chronic pancreatitis, I chose a study which shows if a biopsy is necessary, where should you do biopsies in chronic pancreatitis? There are not much data on pancreatic cysts. In pancreatic cancer, I would like to highlight the importance of checking for exocrine pancreatic insufficiency. And as I said, I would briefly touch on the other topics. So this is a randomized control trial looking at what kind of fluids should we give, a normal saline versus a balanced solution. And for those of you, DDW could be very confusing with 5,000 posters. Posters of distinctions are usually typically the top 10% of scientifically excellent studies. So that's why you see that badge poster of distinction. So intravenous fluid therapy, we all know, is a cornerstone in the management of acute pancreatitis. We have been giving crystalloid solutions, and there have been some data on looking at balanced solutions. The problem with normal saline, as you all know, when you give a high dose of normal saline, you give high supraphysiological levels of chloride is administered along with normal saline. So this in turn can cause hyperchloremia. Hyperchloremia in turn can cause kidney injury and can cause negative outcomes. There have been studies that are done that looked at normal saline versus balanced solutions in acute pancreatitis. The problem is so far these studies have low to moderate quality of evidence and the results have been mixed. So this study looks at the effect of balanced solution versus normal saline and on the chloride levels and clinical outcomes. Again, it's a multi-center study that were looked at. Patients were included if they presented within 72 hours of the onset of symptoms. As you can see, are higher, the CRP levels are higher because they're looking at moderate pancreatitis. All sites initially used normal saline, subsequently switched to a balanced solution, which is sterofundin. I think this is available in India at a predetermined and randomly allocated time. Again, the primary endpoint is here looking at the chloride concentration, and they also looked at some clinical values. If you look at the graph on the right side of my screen, you would see that 259 patients were enrolled, 147 were in the saline group, and about 112 in the sterofundin group. Again, the endpoint was to look at the chloride levels. The red bar here indicates the chloride levels when you gave high doses of saline versus the blue bar, which was there in the balanced solution. And if you look at it, there was a statistically significant difference in the serum chloride levels. What does that mean for us clinically? You know, we're not going to tell somebody that your chloride levels are high. Clinically, what it showed is that there has been a lower incidence of systemic inflammatory response and also the increased amount of organ failure free days, and creatinine levels have been low. And we all know that organ failure is not good when we talk about acute pancreatitis. Again, this is the conclusion of the study is that among those who have received balanced solutions, the chloride levels are low. Again, systemic inflammatory response is low. Organ failure free days have been higher in the balanced solution group, and it overall shows clinical benefits. So what do we know so far with IV hydration? We all know that there is no definite therapy for pharmacotherapy for acute pancreatitis. We just manage them supportively. The pathophysiology seems to be pancreatic hypoperfusion. And when you have hypoperfusion of the pancreas, it could lead to necrosis and death of the gland. And lactated ringers have also shown to have some anti-inflammatory property. That's why we use them. It's a crystalloid solution. The rate and volume of fluid hydration has been unclear, though all the societies and major guidelines do recommend aggressive IV hydration. We have some data that show that over-aggressive early resuscitation can lead to poor outcomes, including sepsis and death. So what we know now is that we probably do moderately aggressive IV hydration, which is 1.5 milliliters per kilogram per hour, which is a fluid bolus that you administer initially, and subsequently you maintain them at about 10 ml per kilogram, as long as the patient is showing some volume depletion or hypovolemia. Again, you do not want to overhydrate these patients because there is concern for poorer outcomes. So what is new in this study? That balanced solutions possibly can have better clinical outcomes due to physiological and chloride levels. Again, we see a lot of patients with acute pancreatitis. I thought this was an interesting study that looked at preventing hospitalizations in mild acute pancreatitis with emergency department protocols, outcomes, and predictors of discharge. Who are the patients that we can triage and potentially discharge home? As we all know, day to day, we see a lot of patients with acute pancreatitis. It contributes significantly to the cost, the hospitalizations, and recently with COVID, we had a lot of bed shortage as well. And I presented a study last year looking at how we can send these patients home safely and manage them from home. This is an extension of a similar study. 5 years back, the same group looked at emergency department pathway to identify the patients who can be safely discharged home. In between 2016 and 2021, of 5 years, they have accumulated data. All these patients were initially evaluated in the emergency room. They were given early feeding after 3 hours, reassessed, and then decided whether they could be sent home or not. They looked at 30-day readmission rates, length of stay if they're admitted to the hospital, the costs, and also the number of imaging studies that these patients underwent. Here is a flow chart. There are 619 patients, and rightfully so, only 200 patients had severe pancreatitis or moderate that needed admission, so these were excluded. Out of the 419 patients, 100 patients went through the ED protocol, and 310 were admitted because it's still a new protocol and people needed to be comfortable with it. So when you looked at this algorithm, and I'm not going to go into detail, these slides are available. First, you confirm the diagnosis, you give lot IV fluids, and they determine the severity. And for those who have mild acute pancreatitis, you watch them for about 3 hours, feed them, see if they're doing well. If they're not improving, watch them for another 8 hours or so before you decide whether you want to admit or not. And when you do the discharge planning, you send them home and then monitor them clinically. In the previous studies, there have been nurses who were sent home to monitor these patients. And in this particular study, they did not have any nursing staff visit them. Again, if you look at the cohort, those who were admitted versus those who were sent from emergency department home, the age group seems to be a slightly younger group that went home, about 50 years or so. And among the causes of pancreatitis, idiopathic pancreatitis and biliary pancreatitis seem to do well when they were sent home. Again, in this slide, you can see that the mean time to refeeding is much lower when you send these patients home through early triage protocols. And the number of imaging studies that were done also in this group is much lower. So what do we learn from this study? That if you do an observation pathway from the emergency department, it's probably safe for us to discharge patients home with mild acute pancreatitis. But who are the patients that you can actually safely send them home and not worry about? Those who have age less than 50 years, and those who have idiopathic pancreatitis, and those who have a good creatinine clearance or a creatinine clearance less than 2, this is the group that you can probably safely send them home. And it has a potential for cost savings and also valuable resources, especially when there is shortage of hospital beds. So ED triage is feasible in mild pancreatitis. We have had studies that showed that with biliary pancreatitis, you want to do index cholecystectomy, otherwise there's increased risk of readmission. You can probably send home nurses, but what is new in this study is that identifying who can actually be sent home safely. Idiopathic acute pancreatitis, those who are less than 50 years of age, and those who have a good creatinine clearance, these are the patients you can safely discharge home with a good clinical pathway. And obviously, we need more studies to be done. It does have a clinical implication that you can reduce the need for admissions, investigations, and cost savings that are potentially great. This I'm going to talk about briefly because there's not very robust data, but we are all asked every day about doing potentially ERCPs for recurrent acute pancreatitis, especially idiopathic recurrent acute pancreatitis. It's a topic that is closer to me. So this study looked at comparing the frequency and time of recurrence. So the problem with recurrent acute pancreatitis is when you do an intervention, you do not know if your intervention is actually doing any benefit to the patient because these patients do tend to have recurrent episodes. So this cohort was looked at those with and without pathogenic gene mutations. Is there a difference? Because people always thought they're genetically predisposed. So this particular study tried to look at it. It's not a very robust study. It was a retrospective study, and not everybody underwent testing by any standardized protocol. The definition of pancreatitis, though, was done well. They looked at two, at least, imaging documented acute pancreatitis episodes, and those who had cancers or chronic pancreatitis and other etiologies were excluded. Genetic testing, as I said, was done. So 138 recurrent acute pancreatitis patients were looked at. Genetic testing was done in about 138, and 78 or half of them underwent ERCPs. And if you can look at this, the gene mutations were seen in at least about a third of the patients, or 37. And that included patients with pancreas division, where about a fourth of the patients actually did have some gene mutations. The result is that there was no significant difference in the median time for the first episode of acute pancreatitis after the ERCP that was performed for recurrent acute pancreatitis. It did not make a difference. 43 days in group 1, 45 days in group 2, with or without genetic mutations. So 3/4 of the patients with idiopathic recurrent acute pancreatitis, whether they had presence or absence of pathogenic mutations, including those with pancreas division, do experience recurrences of acute pancreatitis. So you are unnecessarily exposing these patients to an ERCP, which has probably not done anything, because in 6 months, most of these patients ended up having acute pancreatitis. So what do we know so far with idiopathic recurrent acute pancreatitis? The population seems to have some genetic mutations. The problem is we do not know whether there is any cause association, what is the effect of mutation on the response to therapy. We do not have any robust natural history data. So risk of recurrences is high even in patients undergoing ERCP. And you know ERCP is not a benign procedure, so please be careful and cautious in offering ERCP for diagnosis or treatment of recurrent acute pancreatitis. One should not undergo ERCP for diagnosis, at least. So moving on to chronic pancreatitis, and we see a lot of chronic pancreatitis in India as well. So this is a study that's coming out of Johns Hopkins looking at histological fibrosis. This is very similar in proximal and distal pancreas. And they had the best study group. They looked at the patients who underwent total pancreatectomy and islet autocell transplant. So you have the entire pancreas to look at. And they looked at the fibrosis to proximal and distal areas of the pancreas. So excisional biopsies were performed either from the head or body tail. And they used two validated scores, the Aman scores, which looked at the focal diffuse or perilobular intralobular fibrosis. And they also looked at the fibrosis score. And two pathologists have evaluated, and there is a discrepancy. They actually got together and resolved it by consensus. And paired sample tests were done because there were two groups. Not much difference in the demographic features, and I'm not going to labor on this. The BMIs were low. Some of them did have diabetes. And if you look at the proximal and distal pancreas and the fibrosis and both by Aman score and the fibrosis scores were very similar between proximal and distal pancreas. There was no difference at all. So histological fibrosis seems to be similar both in proximal and distal pancreatitis. And conventional paradigm for us is that fibrosis is patchy in nature, so you probably cannot diagnose pancreatitis by biopsying one area or the other. So what this study tells us is it's likely not heterogeneous, and maybe just biopsying one area, if biopsy is needed, is probably adequate. So what do we know so far? That pancreatic volume and pancreatic atrophy do not actually correlate with chronic pancreatitis. We face that every day. You cannot look at the scan and tell you have chronic pancreatitis. consensus guidelines have been established based on histological features of chronic pancreatitis, though we do not use histology day-to-day clinical practice to diagnose. We don't biopsy. And what this study also suggests is probably histology is not the gold standard because we do not have any definite histological features to diagnose or the disease or to assess severity. We cannot say, like cirrhosis, this is the end stage of the pancreas. And histological fibrosis, unfortunately, does not correlate with clinical chronic pancreatitis. So what is unknown is the role of biopsy. That's why you don't get requests for biopsy like you do in liver. Clinical correlation is lacking and distribution of fibrosis is not known, which area you should look at. What is new from this study is that the distribution of fibrosis seems to uniform. It challenges the conventional paradigm that fibrosis is patchy in nature, and location of biopsy does not matter where you biopsy these patients from. Again, with a caveat, do we really need to biopsy the pancreas? As I said, pancreatic cysts, there are not much data based on what we have been doing clinically, and when I talk to my colleagues everywhere, cyst fluid glucose has been increasingly used to suspect neoplasia, and we discussed some studies regarding this last year. So I'll move on to pancreatic cancer because it afflicts all regions of the world and is one of the most common causes of cancer-related death currently. And this is a study coming out of Mass General Hospital. Again, it was a very good study looking at exocrine pancreatic insufficiency, what kind of workup is done even at a tertiary care center, and pancreatic enzyme replacement therapy. So the authors put in the abstract heading itself that they are inconsistently provided to the patients with both resectable versus metastatic pancreatic cancer. So pancreatic cancer patients, we all know, suffer from both exocrine pancreatic insufficiency because the tumor replaces the healthy parenchyma, pancreatic duct obstruction happens, and when they undergo surgery, you have resected a portion of the gland, chemotherapy can affect. So there are various causes why patients with pancreatic cancer actually face exocrine pancreatic insufficiency. Weight loss and steatorrhea greatly impact the quality of life. We know that from prior data. And the pancreatic enzyme replacement, or PERT, has been linked to increased survival. Imagine we're talking about a disease where the survival is dismal and you just give enzyme replacement and your survival goes up. So it's not a bad deal, and I don't think we should ignore that. So the aim of this study is to describe a cohort of pancreatic cancer patients at Mass General Hospital looking at pancreatic, what kind of workup and enzyme replacement was done. It's a retrospective study. The robust number of patients that were identified for 449 patients. Those about 150 or 200 were excluded because they underwent surgery, some declined treatment, and 56 had tumor upstream. So they took all the clinical data, including the treatment approach, symptoms of the patients, fecal elastase levels were checked to look for exocrine pancreatic insufficiency, and they also looked at the enzyme usage in this population. So 97 patients underwent surgical resection, and 153 received non-surgical treatment. So close to about 250 patients were studied. Half of them were male. If you look at the pancreatic insufficiency symptoms, about 58% in the metastatic group and 68% in the surgical group. So that over half of the patients clearly had symptoms of exocrine pancreatic insufficiency. However, when you looked at fecal elastase level, only 2% of the patients underwent testing in the metastatic group and 9% in the surgical group. A dismal number of patients underwent actually testing, which is fine. You don't need to test everybody, right, as long as you treat. But if you look at the treatment group, pancreatic enzyme replacement therapy was prescribed only in about half of the patients with metastatic group and a little bit higher, about a third of the patients in the surgical group. When you gave enzyme replacement therapy, what is interesting is that about a third of the patients in the metastatic group had complete resolution of symptoms, and close to a half of the group in the surgery had resolution of their symptoms. Now, what symptoms are we talking about? Weight loss, diarrhea, steatorrhea, fecal elastase. These three things, and fecal elastase, as you know, was checked in a very small percentage of patients. And when you treated them, a majority of them actually did respond to treatment. So pancreatic insufficiency is common in those with metastatic and post-surgical patients with pancreatic cancer. Less than 10% underwent testing. And when pancreatic enzyme replacement therapy is done, look at the amount of dose that was given, only about 18,000 to 20,000 units. And I know our panel here will tell you that we probably need to give about 70,000, 72,000 units of lipase per meal. So they were grossly underdosed when they were given. Even then, a significant number of patients seem to have improved. So there is a lot of variability in clinical practice. So the one important thing that I want you guys to take home today is that pooled prevalence of exocrine pancreatic cancer, even in advanced pancreatic cancer, is about 72%. And pancreatic insufficiency is significantly higher when the tumors are located in the pancreatic head. And if you look at the big number, about 3.8 months survival benefit with and just the enzyme replacement therapy. So that is a huge thing. We're not talking about toxic chemotherapy, radiation, expensive treatments, just enzyme replacement therapy alone has had a significant survival benefit. I don't think in oncological terms you would have a better survival with any other treatment. And patients receiving PERT had a tendency towards better quality of life. So what is new in this study? Assessment and treatment, even in specialized institutions, is very low and is variable. And think of a pancreatic insufficiency and enzyme replacement therapy when you're dealing with patients with pancreatic cancer. Obviously, we need large multi-center studies with heterogeneity because we're talking about one institution in Massachusetts. Switching gears to translational studies here, as I said, I just want to pique your interest in what is happening and what is new and how can we adopt and do more studies in translational medicine. And here is a slide that shows a preliminary randomized double-blind placebo-controlled trial on safety and efficacy of human bone marrow-derived mesenchymal stem cells. And I know there are some centers in India that are doing stem cell research. And what this human derived mesenchymal stem cells do is they do exactly what you want when you have inflammation. They decrease your pro-inflammatory cytokines, which is TNF alpha, interleukin 1, interleukin 6, and they actually improve your anti-inflammatory cytokines, IL-4 and IL-10. It's a perfect thing, right? So you're reducing the inflammation and you're increasing your anti-inflammatory cytokines. We all know acute pancreatitis is autodigestive process activated by digestive enzyme. And mesenchymal stem cells have both immunosuppressive and immunomodulator activity. And animal studies have actually shown that there is an improvement in tissue edema when these are administered. So the aim of this study is to look at what is the effect of these mesenchymal stem cells in moderate to severe acute pancreatitis. It's a first human study done in a multi-center fashion. Patients greater than 19 years, again, those who had severe or moderately severe pancreatitis were included. They all needed to come to the hospital in 72 hours. And these, I will not get into the detail, but bone marrow is harvested. The mesenchymal stem cells are extracted. Based on this, I don't do basic science research. It seems very easy to extract these things. And they looked at the primary outcome, which was clinically relevant. They looked at modified Marshall score at day 7, and they also look at what we commonly use, the CTSI or the Balthazar scores at day 28 in these patients. And secondary outcomes, of course, they measured the inflammatory cytokines, the CRP levels, TNF alpha, and interleukin 6. So 36 patients were so far randomized, and when we looked at it, there is a significantly higher reduction than placebo in these patients when you look at the inflammatory cytokines. And they also had CT indexes that were significantly better compared to baseline in those who have received the mesenchymal stem cells. So both TNF alpha, interleukin 6, and everything has significantly improved. And more importantly, because it's a first in human study, there were no adverse events that were related to the drug that occurred. That's the critical thing. So it seems that it is safe, and it at least reduces the inflammatory cytokines, and there is an improvement in the CT scores. So the conclusion from this study is that the safety profile is good, and we might have something that has a potential role in acute pancreatitis because of its anti-inflammatory properties. So what do we know so far? Acute pancreatitis, we all know, has significant morbidity and mortality. There are no specific treatments, and stem cells seem to have anti-inflammatory and regenerative properties. What is new here is that it seems safe and appears to reduce the inflammatory markers and CT severity. Clinical applications, it's that it's easy to derive. It can probably be used in other digestive diseases, anti-inflammatory conditions. When you have like diseases like IBD or other areas of inflammation, you could potentially use them. But for acute pancreatitis, it seems to be safe based on the pilot study. We talked about pancreatic insufficiency and enzymes in the previous studies. EPI is used caused by inflammation or pancreatic tumors, as we know. This study looked at a substance called silase. It's a new recombinant microbial lipase from Tetrahymena thermophilia. So it is produced by bacteria. So current enzyme therapies, we all know they don't normalize fat absorption. We still struggle. And you need to take a lot of pills. There is a high pill burden. Lack of availability of enzymes uniformly is also a problem. So the ideal pill should be small, low pill burden. You need to have a high dose of enzymes packed into a small pill. And ideally, it should be non-enteric coated because some of the processes of digestion occurs in the stomach as well, and it needs to be stable at the lower pH. So that's what exactly these investigators tried to do, is to produce a low pill burden and high safety and better enzyme supplement. So they did this in an animal model where they have ligated the pancreatic duct and created chronic pancreatitis. I'll draw your attention to a couple of things. So if you look at the pH, the drug seems to be effective even in acidic pHs, works well in alkaline pH, kind of mimics your normal digestion of food. It is very stable at various pHs. About 80-90% of the drug is still available at a lower pH. And if you look at the size here, it's significantly smaller compared to your conventional Creon or other commercially available pancreatic enzyme replacements. And if you look at the coefficient of fat absorption, these are healthy people. When you do not give any treatment, your coefficient fat absorption is very low, about a fourth of what normally occurs. And when you give a commercially available drug, it's about 77. And this one comes up very close to the commercially available product. So it seems to be very highly efficient drug that was generated using a microbial lipase. So we know EPI is very common. Maldigestion of fats, proteins, and starches occurs. And typically you need a lot of medications derived from porcine pancreas. It is a problem for some people to take porcine pancreas pills, and also allergies and costs are quite high at this time. And we know that it does not eliminate steatorrhea, so patients are less willing to take these medications. What we do not know is that the physiology of endogenous lipase, we do not understand it very fully well. And the suitable microbial lipase is hard to make. Those who are interested in this topic, I would urge you to look at this paper by Mark Lowe and Whitcomb. They have described in great detail what our current problems are. And what is new in this study is that recombinant microbial lipase can overcome the issues that we talked about. And the clinical implications of this is that the recombinant lipase alone or in combination with amylase might be feasible, and we need larger human studies. And I think there is potential for this. We all struggle to study, and now we are in the modes of 3D printing, and that has come into human body organs as well. And this is just one slide I'm going to talk about. It's a 3D bioprinted in vitro model of a patient-derived pancreas to study. So right now we do all the studies based on animal models. And it's very hard sometimes to take an animal model study and apply that to the human beings. So this is a bioprinted organoid that was looked at. There was 90% cell viability, and even the ducts and other structures started developing in the bioprinted models. So what the conclusion is that it is feasible for us to actually bioprint a 3D model for pancreas, so we can study specific exocrine and endocrine functions, and probably in the future will help us with personalized treatments. So for those of us who do endotherapy for chronic pancreatitis, the pain in chronic pancreatitis is also poorly understood, despite the fact that we have multiple centers specializing in pancreas disease. The pathophysiology we think is because of pancreatic duct hypertension causing pressure, ischemia, and also some neuropathic changes that occur around the pancreas that cause the pain. So we conventionally go do ERCPs and we're hoping that we relieve the pressure in the pancreatic duct, but we do not know whether the high pancreatic pressures, when you relieve them, do they have clinical response and what happens to the gland? So here is an MRI sequence that was created, and they looked at with the novel technology, looking at the pressure. And in fact, this study was done at AIG, where you're sitting right now. And this was validated using an ERCP, where they used a cardiac catheter to measure the pressures. Those of you from the SOD days, like myself, we all know the pain of putting in a catheter into the pancreatic duct, measuring pressures, and causing pancreatitis to patients. So this process circumvents that need for invasive pressure measurements. 6 patients were studied. It's a single center, again, 3 with mild pain and 3 with severe pain. And when you look at the patients with high pressure gradient who underwent pancreatic sphincterotomy, about 2 out of 3 or 2/3 have responded to intervention. So MRCP-based pressure measurement can predict response to intervention based on this very small pilot study. Again, what do we know? Pathobiology of pain is unclear. Pancreatic ductal hypertension versus neuropathy or a combination do cause pain. Pancreatic duct interventions and effects is unclear at this time. And measurement of PD pressures is not always reliable and currently is an invasive way to measure. So what is new in this? That we probably have a non-invasive way to predict pressures, and pressure measurements might have a response it clinically might be relevant when you say which patients should undergo ERCP. If your pressure is high and if you're having pain, maybe those are the patients that you should take them for endotherapy. So there is a potential clinical application for this. Obviously, we need larger studies with data from multiple centers. Artificial intelligence, I'm going to wrap up in the next couple of minutes so we have enough time for discussion. I don't want to waste the expertise of all the panel that is sitting here. Whole organ pancreatic fat assessment using artificial intelligence. Last year, we discussed that some studies looking at intrapancreatic fat, and there are other studies that looked at intrapancreatic fat as a risk factor for both benign and pancreatic disease. We all know that MRI can quantify intrapancreatic fat. Intrapancreatic fat is heterogeneous, so measurement of one area, just like in cirrhosis, might be a problem. And the way they measure it is by using proton density fat fractionation, or PDFF. And from there, using either 2D models or 3D models for measurement, there were 217 patients with 245 MRIs that were looked at. There was a significant variability when a 2D model was used and the PDFF was measured in these individuals. So the conclusion was that 3D imaging is 3D whole pancreas PDFF measurements are more reliable, and this can be done very easily with use of artificial intelligence. And so intrapancreatic fat, we know, is not good. There are data that are evolving that it could be involved with diabetes mellitus, acute pancreatitis, and pancreatic cancer. And methods of measurement of intrapancreatic fat currently is not standardized because the position of fat is not uniform. And artificial intelligence probably can help us with measurements of these intrapancreatic fat. So in the future, maybe your software for the MRI machine would come with AI that can measure it for us and help us with disease prognostication and management. I expect that this will come sooner rather than later, so it would help us manage our patients better. Similar concept was applied in a high-risk population of pancreatic cancer. Again, this comes from the Johns Hopkins group, which does have a large registry of screening high-risk individuals for pancreatic cancer. The surveillance currently is done, as you know, it's an imperfect tool. We do endoscopic ultrasound or MRI. Current guidelines do recommend both. And this study looked at using EUS texture features in pancreatic parenchyma of those who underwent surgery to identify how the AI can target these lesions and help us. Again, pathology we did have, whether these pan-ins or pancreatic intraepithelial neoplasias were either low grade or high grade, or whether they had cancers. So these images were taken, images of interest were looked at, the tissue texture was used, and they created an XGBoost model. And there were 41 high-risk individuals during surveillance that underwent surgery. They took good quality US images. And when they applied artificial intelligence, if you look at it, the sensitivity was quite high, about 70%, specificity was 80%, and accuracy was pretty good. So what it tells us is that the texture in the US images can be quantified, and AI models can help us better predict neoplasia. It's much better than what you do now with estimation of fibrosis on the current EUS scans. So what do we know so far? Screening is considered in high-risk population, especially those with genetic risk. Currently use MRI and endoscopic ultrasound, either in combination or alternately every 12 months. In Europe, they do both in the same year. Here in the United States, we alternate. There is a significant limitation because when you identify any lesion, it's already late. The cat is out of the bag because we are not detecting precancerous lesions like a polyp. We are identifying cancer once this comes. So the whole idea is to identify it early. So artificial intelligence has a potential role for identifying early lesions and help us with accurate detection. And there is a new area that is evolving that is called radiomic analysis that's looking at deep learning of medical imaging for identifying the lesions. So there are a couple of Indian studies at DDW, and I will leave it to the panel to discuss because I do not use olinistatin, and I know this question keeps coming up for post-ERCP pancreatitis. Again, it's a single center study that looked at 172 high-risk patients undergoing ERCP. 1 lakh units was given. Post-ERCP pancreatitis was still about 6.39%, 7%, which it seems to be what most centers are these days with all the care that we take. The second study was interesting. It looked at association of diabetic status in patients with pancreatic ductal adenocarcinoma and the effect of tumor resection. It's done at PGI Chandigarh. So it looks like diabetes mellitus, especially recent onset, as we know from other data, was more prevalent in pancreatic cancer. And preoperative diabetes mellitus did not impact clinical outcomes. And diabetes actually improved after surgical resection. So if I can get your attention for another 2 minutes, in summary, what we talked this morning, or this evening, I'm sorry for you, is that in acute pancreatitis, moderately aggressive fluid resuscitation, preferably a balanced solution is what we should use. Those with mild idiopathic acute pancreatitis, especially younger patients less than 50 years of age who have good creatinine clearance, can be discharged home and potentially managed as outpatients. Those with recurrent acute pancreatitis, especially idiopathic recurrent acute pancreatitis, do not do ERCPs because despite ERCPs, these patients do have recurrences in less than 6 months. So please avoid ERCPs so you can avoid complications. We know currently that there is no gold standard for diagnosis of chronic pancreatitis. If biopsy it needs to be done, again, this is a big question mark because we do not have accurate histological criteria. It seems like you could do it anywhere, and fibrosis seems to be uniform as opposed to our conventional wisdom that fibrosis is patchy. And as I said, there is increased use of cyst fluid glucose for differentiation of neoplastic cysts. And when you're looking at pancreatic cancer patients with dismal outcomes and prognosis, a simple intervention like giving pancreatic enzyme replacement therapy seems to make a big impact. So think EPI and PERT when you see a patient with pancreatic cancer. I would like you to pay attention to what is evolving. That's human bone marrow derived mesenchymal stem cells have an anti-inflammatory and regenerative properties. And not only in acute pancreatitis, but it might have a role in other inflammatory conditions. Recombinant microbial lipase seems to be easy to make, low volume and effective, and might replace our current PERT models. Non-invasive PD measurement could identify candidates likely to respond to endotherapy. That was the novel study from Hyderabad that I just showed. Intrapancreatic fat is potentially pathogenic, and ideally you need a whole body pancreatic fat. And hopefully our machines will be fitted with AI that can help us predict and measure them accurately for us. AI seems to also have a role in helping us with early detection of pancreatic lesions, both in US and MRI. And before I turn it over to Naresh, Mohan, and others on the stage, I'd like to thank you guys for your attention and coming here. And for those of you who are fathers, who are lucky to have your fathers, have godfathers and father-like figures, happy Father's Day.
Thanks, Nalini. I must congratulate you for all this hard work that you've done. Looking at so many abstracts, uh, picking out the few which may be relevant and then trying to summarize it for us. And of course, trying to stay awake very early in the morning there in Wisconsin. Would you be staying online or would you going
Yes,
back to bed?
yeah.
Okay. Let's start the discussion. Maybe first, Rajiv, would you like to comment on this business of the choice of fluid in acute pancreatitis? The last couple of years, we've had these swings, more fluid, less fluid, just enough fluid. And now they said Ringer's lactate is good, is anti-inflammatory. And now they're suggesting that you use a balanced fluid, which doesn't contain lactate. So your comments.
No, for acute pancreatitis, there are two things which is important. One is the amount of fluid, and second, what is the fluid to be given. Amount of fluid, now, no doubt about, after the waterfall trial, it has been shown that moderate resuscitation is always better, and now we all are experiencing the same thing because this unnecessary increases volume overload, pulmonary edema, etc. So that part is now very much clear in absence of hyponatremia. About the fluid part, balanced fluid where there is no chloride, but in spite of chloride, there is either acetate or a lactate, act as a buffer, act as a bicarbonate precursor. So both are usually same. They are near about the plasma. They are isotonic. But the problem of a normal saline is hyperchloremic metabolic acidosis leads to an AKI. So we have a good data about a Ringer lactate, which is easily available in our country as compared to which is the B Brown solution serofundin. So for us, Ringer lactate, and there is one trial which we are one of the parties, a Waterland trial, which Spanish group is doing a trial with the same group which did the waterfall trial. So the trial is comparing Ringer lactate versus normal saline. So to given this abstract, of course, both are equally good, Ringer lactate and the serofundin. But in our country, probably Ringer lactate is easily available, very cheap. So preferably for our country, Ringer lactate is a better. And we have a good amount of literature support for Ringer lactate also.
So, Nilay, would you be in a hurry to change your practice with Nalini Guda's information? And tell you one more thing. I mean, this hyperchloremic, they looked at just the chloride values. And my impression was hyperchloremia had long-term effects. Is there any short-term effect that we really need to be worried about?
Yeah, so first thing is first about this more fluid, less fluid. Now Nalini Guda's slide in one of the things showed 1.5 ml per kg per hour is the moderate. So if a patient is 60 kg, then you give just 90 ml per hour.
Per 1.5 per kg. Yeah.
Yes, but
After the
initially
initial
there are
bolus.
two hours is a bolus dose.
Yeah.
And
So
after 2 hours,
you
there
give
is
5-10 bolus, and then you give 1.5 ml per kg per hour.
correct.
So if it is a 60 kg per
Yes,
patient, you
yes.
give 90 ml per hour.
Correct.
So is that fluid good enough?
See, there are many
It's
parameters.
not good enough.
No, there are many
So
parameters.
you don't give 200 ml per kg, but you don't give 90 ml per kg for a 60 kg human being. I don't think. Let's take our audience.
So, Nile, the
Give
same-
less than 100 ml per kg, 100 ml per hour in acute pancreatitis setting.
Nile, that's what we studied in the waterfall trial. Initially, for first few cases, we are also very skeptical about giving a less fluid. But when we realize the less fluid is actually causing a good to the patients. See, if you measure the urine output, 0.3 ml per kg per hour is quite good enough for a perfusion in pancreas. Suppose, and there is a criteria. It's not a point blank. You give 1.5. If the patient is showing a signs of hypovolemia, if the urine output drop, and you definitely go
Yes.
up in the fluids.
Yes.
Yeah, I
So
think
it
the
is- it is-
bottom
it is-
line was euvolemia. I think
Absolutely.
Ali mentioned that. I think that's really the.
Yes, that is very important. You just, rather than saying 1.5, you measure urine output and you measure the pressures. Second thing is, the fluid we are talking about actually contains too much of chloride. It has sodium chloride, it has potassium chloride, it has calcium chloride, and it has magnesium chloride. I have not used that solution, but I just looked into the net, and that is what the composition is. Sodium chloride 0.68 grams, potassium chloride 0.03 grams, calcium chloride 0.037, magnesium chloride 0.02 grams, and then it has acetate, which is 0.327 grams, and malic acid.
I think it's related to the sodium as well. The more sodium you give, the more chloride that is there. Rajiv?
No, see, Nilay, see, basically the magnesium and all are acting as a buffer in isotonic solution where we call it as a balanced solution. Otherwise, it's non-balanced solution like a normal saline, which contains only sodium and potassium, sodium and chloride both. So even if this all chloride, the chloride level of serofundin, Dr. Nalini, is not exceeding 94, 95, exactly like a plasma. Am I right?
Yes.
See,
That is what
So
I don't use it, but that's what I looked at, and that's why they called it a balanced solution.
yes, it's a 94 to 100 chloride level.
Yes, so it has less chloride than normal saline, but probably more chloride than ringal lactate. Almost similar. So
It's
I
actually
don't-
very similar.
As Rajiv, you said, we have ringal lactate. Why do you want to give something which is more costly? And yes, about the chloride. Yes.
No, no, with buffer, when your lactate converted into the, so your base excess is acidic.
If you can use a mic,
No, we
No,
can.
I think the rest of us can hear what you say.
Yeah, about that chloride thing again. Hyperchloremia does cause renal failure. It's very clear. So if patient is receiving only saline in a very high dose, he is bound to get hyperchloremia and renal failure. But most of us don't use too much of saline. Most of the times we do use ringal lactate. Only contraindication is hypercalcemia. Otherwise, we all use ringal lactate.
Yes, and a liver failure with the lactate.
So can I conclude that possibly this balanced solution is not going to find too much favor in our practice at present?
No, sir. The ringal lactate itself is a balanced solution. There are balanced solutions are available: ringal lactate, plasma light, and ringer acetate
Okay,
light.
all right.
So it is similar. Balanced solution is a treatment of choice for the fluid in a pancreatitis. In our country, a ringer lactate.
Yeah, but
all right.
it's not classified. Is there anything written that ringal lactate is classified as a balanced
Yes.
solution?
It's a balanced fluid. Anything which is it's a buffer. Either it's a lactate or an acetate. So lactate has a problem with the renal and the liver. So they came with Ringer's acetate. So and that's why they have an acetate in the serofundin.
Okay. So I think the last question that I wanted to ask you, Rajiv, is they said better outcomes. I mean, what did they mean by better outcomes? Did they show that in the paper or just, or Nalli, would you like to take that up?
Because your creatinine levels were better, the renal failure is a bad outcome in acute pancreatitis. So that's what they're looking at. And again, it's just an abstract. I have to wait for the full paper to come out. It looks like Rana has an answer. I see he's reaching for the mic.
No, I just wanted to clarify a few things. Stereofundin or ringer lactate, there is a difference in chloride. So stereofundin has higher chloride as compared to lactate. Lactate has about 100 and stereofundin is 127. Sodium chloride goes to 145. So that's the difference in chloride. But you have to understand stereofundin is decreasing the mortality or morbidities by decreasing the incidence of kidney injuries. But then, one size is not going to fit all patients. You will have patients who have hyperkalemia, who have AKI already setting in. In those people, I think you'll have to, moderate your solution, and stereofundin would not be a, appropriate solution in those situations.
And in this study also, they have not mentioned how early the feeding started.
Yeah.
See, this is very critical. So for 7 days, they are just giving either normal saline or normal saline. So when the feeding started, it is also important when the patient started eating or feeding, which is a early. Now we are encouraging them to start early feeding within 48 hours. Then probably automatically our IV fluid requirement will go down.
I think probably the message is it's a promising solution, but right now I think the practice of using RL should stand. It's an expensive solution, so we need more data to convincingly show that it's better than existing practice of using a RL or NS.
Okay, we'll go to the next thing again. This early discharge from the ER. Rajiv, would you again comment on this? My concern is how long did these patients stay in the ER, and is this what we do in our country? These patients were there almost for maybe half a day or more in the ERs. That's perhaps a practice in the US. How often does it occur in our setting? What happens to those patients who are perceived severity, obese, comorbid, and things like that? Do they all get clubbed in this? But I think there Nalini said that you exclude patients who are old and so on. But your comments on this?
Basically, acute pancreatitis comes to a secondary center, not a tertiary center. So secondary to center where the physicians are handling, they are really panic after seeing the 1,500 or 5,000 lipase. So immediately patient goes into the ICUs. That's usual practice in our country. Suppose if the patient is seen by a gastroenterologist who has a lot of experience of seeing an acute or chronic pancreatitis, then probably the ED pathway is probably helpful where you have a load of an acute pancreatitis in your setup. But this is a fantastic paper very relevant to our country, where we keep sometimes unnecessary patients mild pancreatitis, which is a major chunk of acute pancreatitis, and unnecessary increasing the cost to the patients. So ED, we have a harmless acute pancreatitis score, which is quite good, has got a good positive predictive value of about 98%. So we can judge roughly into the emergency department if patient comes after 7 hours of a pain or 10 hours of a pain, and then see whether the patient is probably going into a mild variety or a non-mild variety.
Roop, let me ask you this question. How confident are you that what you think is mild in the first 12 hours is going to remain mild at the end of 48 or 72 hours?
So I think what we should look for marker which is relevant to the pathophysiology, and the inflammatory response is one of the most important markers that begins from the acinar inflammation to begin with and then goes on downstream. So in my practice, I look for a patient who the SIR score is the most important to me comes, and if he, even though patient is supposed to be having mild, I'll keep him in the ER for at least, not necessarily admit him indoor, and follow the SIRS. If the SIRS is very high, then I admit him, maybe he goes ICU or HD if it is 4 or more.
So I take it that you're not sending them home in 8 or 12 hours. You're still a little concerned and you'd keep them a little longer. Nilay?
If you see the trial, one group of patients they would always admit, most of the times, is biliary pancreatitis. So where we should not be admitting is those patients who are idiopathic, young patient without comorbidity. That's a group we see quite often in young male adult or male young, like 10 to 20 years old. So this paper would tell us that probably in these patients, if patient has mild pancreatitis, we can always not admit and give liquids orally or something and send them home. That is what my take. And as Rajiv said, it's an excellent paper because probably many of us do this for this group of patients, but then it tells you that yes, you can do it.
Surinder, I think this data would be most relevant to you in PGI, where you don't have place to admit patients and you don't want to admit them. How sure are you that, or confident are you that you'll be able to train your ER physician to be able to take this decision?
I think it's a very good paper, and the message which the paper has given is a good message for triage. At our institute, I think the problem is that all the patients who come to the emergency are all severe pancreatitis. So the dilemma of discharging those mild, we usually don't face in our AR. All are severe who have been referred. But I think it's a good paper with a good message. As Dr. Rajiv talked about at secondary care centers, this would probably help in better triage of mild pancreatitis, and the ones with these features can be sent back home early.
Roop, last comment on this?
So I'd still be a bit concerned because, okay, there will be a subgroup of patient who looks very benign, just some with pain and little bit elevation. That's a separate subgroup. But then if we go by the molecular events in acute pancreas, it's a very dynamic process. And we do not know what they go home. So I'd still be concerned with majority of these patients observed.
So a small minority maybe
Yeah.
would fit into this, maybe a larger in the practice in Gujarat, maybe nil in Punjab, and maybe some in yours and my practice.
So I think the patients whom we can send with the were never very severe. For biliary, as you said, is yes, we. So
He
that's-
said idiopathic.
Yeah.
So I think that those criteria need to be clear. We'll just go on to the next. This on recurrent acute pancreatitis. Mohan, this business about ERCP being dangerous in these patients, irrespective of whatever their genetic mutation is. Your comments on this?
I think this paper is an interesting paper, but a retrospective and a very poor design actually. This paper was started in 2012, 10 years before that, when I think US and MRCP were still evolving. And that has changed our practice. We are not doing ERCP upfront in acute recurrent pancreatitis. It is still impossible to do. So this paper maybe not relevant now, but it has clear message that don't do ERCP in acute recurrent pancreatitis. Never do it. Presently, we are guided by EUS and MRCP to see the ductal abnormality. But the two important things in paper are the genetic mutations. Whether genetic mutations, a patient who has recurrent pancreatitis and has the genetic mutations, will it benefit by ERCP? So again, the answer was no. But there is another dimension to this is pancreas divism. So now there is a hot topic that whether treating pancreas divism is endoscopically should be done or not. So there is a very good trial going on in US that is known as SHARP trial, including 234 patients, where if you have a pancreas divisum and recurrent pancreatitis, whether you will do an ERCP, patient will benefit or not. So the answer will come with this. But with this retrospective trial, which involved 25% with pancreas divisum, who also had genetic mutation, they also did not benefit by ERCP. So in this small retrospective trial, the message was that even when the pancreas divisum is there, don't jump for ERCP and sphincterotomy. It is still an ongoing research question which needs a bigger answer, and don't jump for ERCP.
Okay, I'll quickly comment on two papers. One is the business of fibrosis in the proximal and distal part. We still, as Nalini said, we don't know how to define chronic pancreatitis. Still, fibrosis is still, we don't know what it means. It means it's a process, but doesn't define the illness. But if you're looking for fibrosis non-invasively, whether you look at the head or the tail, I guess it doesn't matter. Roop, you can if you have anything, you can respond to this, or we go on. Okay. The next was about PERT in cancer patients. I mean, there's no doubt about it that 90 to 100% of these patients do have a problem and they need PERT. And it's not surprising that we would find an equal number of patients in our country who are being deprived of enzyme replacement. And as it shows, there's improvement in quality of life, there's improved survival as well, and they do need it. The only question is, do we really need to do a fecal elastase in them, or we just give it upfront? Nilay, just.
I give most of the times upfront because if you see, there is more atrophy to the pancreatic gland compared to chronic pancreatitis in pancreatic malignancy. I think the message, in fact, is more important to create an awareness. Most of us still don't use PERT in malignancy. Second, yes, we do it after surgery. But that is not the only thing we should be doing. If even if patient is on, say we've done stenting for metastatic disease, these patients do need PERT because it would definitely improve the longevity and nutrition of the patient.
Thank you. We just come to this business about silase, this microbial lipase, Surinder. Are you excited by it?
Yeah, it's an exciting study because we all know the limitations of porcine lipase, which we use in our enzyme preparations. You know, you need high doses, acid labile, you have to give enteric coating, that increases the cost. So this silase, which has been isolated from this protozoa, it is called silase because the protozoa is a ciliate. So it's a lipase from the ciliate, so that's why it is called silase. And previously there have been few studies which have looked at its biochemical properties. This is the first in vitro study which is done in pig model to show that it is protected from the bile lipolysis also. So it is bile stable also, and it has shown promising results. So I think in couple of years we'll have probably clinical studies which, if show the similar results as being in
Maybe just
porcine
a
model.
question to all of you. How many of your patients presently refuse to take the presently available thing because it's porcine in origin?
First of all, we are not telling them this porcine in
Yes,
origin,
yes.
so they don't know. So if we tell them, maybe it might be a different story.
So
That's one aspect. But regarding this efficacy, like this is a good study. There was another study published in Gastro, I think in 2015. So they studied a yeast recombinant lipase from a called Yersinia lipolytica. So that was a very good study, showed very good CFA and good comparison with Creon and others. But that did not really pick up like all these years. So I don't know the reason. So that these things we
I
need
think
to
probably the cost is an important
cost
issue.
is exactly.
Plus, all is recombinant technology. Require a lot of
I only one.
we are a little running short of time, so we just have 2-3 other papers. Roop, this 3D bioprint model that you have to study, how excited are you by this?
So it's a good model just for research. I mean, I saw a sentence, personalized therapy. For personalized therapy, we need to take the pancreatic.
Speak a little louder. You're not.
So if we want to do some research study on resected pancreas to see the crosstalk between the two cells, exocrine and enterocrine interaction, that's a great model. But how much it will help the patient in the long run, I'm not sure as yet.
But to you, as a lab researcher in pancreas, do you think it's something going to be a big?
Yes. For a lab research, it would be good for picking organoids and then putting up, because the crosstalk of cells is very important in this kind of research.
Surinder, this interesting paper from AIG using MR to predict the ductal pressures and then therefore consider ductal hypertension as a cause of pain. How much do you think is going to have an impact in the future?
I think it's a very exciting study, although the sample size is small. We have to understand few limitations. One, we know that there is no direct correlation between ductal pressure and symptoms. We still have patients who will have a decrease in ductal pressure but will not respond to pain. But I think the most important clinical utility of this study or this MR-based non-invasive ductal pressure would be in those patients probably where we have done endotherapy, we have dilated the stricture, put a stent, and patient has still not responded. And we always believe that probably we have done under performance in endotherapy. So if we have found that the pressure has come down pre and post, then probably the endotherapy had been sufficient and the other mechanisms are in play in causing pain. So that would be probably the important clinical utility of this study.
Yes. Is there a matter of time at which time point in the natural history we are looking at? Like if the patient has neuropathic pain, which will come a little bit later if we don't do early endotherapy for it. In those patients, it might be helpful to differentiate is it nociceptive pain or neuropathic.
Yeah, I think that's the next step that will be in this.
It will always be useful to combine
In
both
fact, we
pathology
don't know
and pressure.
In fact, we don't know whether this will work if you already placed a stent.
Roop, I'd like you to comment on both these things, ulinastatin and mesenchymal stem cells. What's your take on this?
Yeah. So ulinastatin is a protease inhibitor primarily, and if we look at the pathophysiology of acute pancreatitis, again, is a protease activation that happens very early, within the first few hours, 4 to 6 hours of the initial insult. When the patient comes to us, it's systemic inflammation. That event is already gone. So in de novo acute pancreatitis, I don't think ulinastatin has a role. There are few studies I know But in the context of post-ERCP pancreatitis, I think it could be an exciting molecule.
Okay, let me have a show of hands. How many of you use ulinastatin in your practice? Here about
For
four.
acute pancreatitis or prevention?
Post-ERCP.
For acute.
4. The vast majority don't. Either,
We
something. Someone is wrong, or where is the problem?
No, it's a old wine in new bottle. It's a very
As long
old-
as it's wine, it's acceptable.
Yeah.
The older the wine, the better.
I think it's been commonly used in Japan and has been approved by their society for not only for acute pancreatitis treatment but also for prevention of post ERCP pancreatitis. And many meta-analyses have shown if you use it before giving, and that too in mild to moderate predicted cases, not in severe cases. So in this study, Sandeep, I think Sandeep Paul has done a very nice study showing first time in high risk patient there was a
Yeah.
reduction.
So he has used it in high risk patient. Only problem with this study for me is all the patients had received stent. We don't know. Of course, yeah.
It made
No, but
difference.
Without
really
stent or without any approved treatment for PEP, it's not ethical to do any study. I think we cannot do a control arm without doing any intervention.
Stem cells, Roop?
Stem cells, actually this study was recently published as a full paper in Gastro. So if we see the study, they did not see any intergroup difference except for CRP. There was no change in the CTSI and other parameters. There was change within the group, like pre and post treatment, which that is something which we don't want. We want to see if there is a difference in the intergroup parameters. And then the other issue here is the mesenchymal stem cells have been shown to inhibit the cytokines, but we need something that works higher than the cytokines, the NF-kappa B level, that's liter of all the cytokines. So if we have something that inhibits NF-kappa B, I think probably that will shut down the whole cytokine crosstalk. But this study, I don't think would find any promise at this point. We need to larger sample sets and better design.
Okay, I'll stick with your Roop. This business about AIA and pancreatic fat reminds me of a statement that said we have found the virus, but virus is searching for a disease. Now we have learned to know, we have finding out ways to find out what this fat is, but what does it really do? And what is it going to translate into the future?
So, fat in the pancreas has been associated with severity of acute pancreatitis or even with cancer or onset of pancreatic cancer in high-risk patients. But what we don't know is the distribution of fat in different parts of the pancreas. Is it directly associated with this event? So this study tells us 3D model using this AI convolutional network shows us better distribution of fat, but we don't know what that means in the real life scenario. So if we have some objective evidence, for example, if fat in the head increases the risk more in cancer, or fat in the body increases the risk of severe acute pancreatitis, then this data would be useful. But
So this is
as
a
of now,
starting point for more research in this
Right.
area.
Yes, because MR-PDFF is well established in liver disease, for the fatty liver disease, and now that everything is moving to MR-PDFF and MRE from transient elastography. So probably that may be one step for a pancreas.
in this study, they were discussing in
three.
different areas of the pancreas.
I'm sorry, AI is something different. It's a machine learning. So where the human mind gets fatigued or where we cannot concentrate. Suppose you want to see the entire pancreas and find a little something wrong somewhere. It's possible. But the AI, because of the machine learning, will tell you, okay, go there and look there, and it will tell you something is wrong there.
Okay, Surinder. Now this brings on to this business about picking up lesions in high-risk individuals. For neoplasms, reasonable sensitivity specificity. But the question is, do we have enough data to feed into our AI for us to get something out of it?
That's a very important point. Pancreatic intraepithelial neoplasia, it's a thing which has been talked a lot about. I don't think so anyone of in our practice who are doing EUS would have picked up a PAN-in. So, and the changes which have been described are very vague, periductal, hypoechoic areas. You've seen a lot of those patients. For last couple of years, we are screening all our new onset diabetics with EUS, and we find these periductal changes, and we really don't know significance. And so far, we haven't found anyone developing pancreatic cancer in these patients. So it's a big challenge. We really don't know how to best pick up PAN-in. But I think it's AI is going to come up in all these places where, as Nile talked about, the human mind gets fatigued. So doing an EUS screening and looking at whole duct and whole parenchyma humanly is difficult. I think AI will probably help us, but we really don't know what is the correct lesion which we need to identify. So what I would suggest is that first screening good is an MR. If you find any stricture in the duct and there is no other explanation for that stricture, then one can do an EUS and carefully look at the periductal areas. And if you find those hypoechoic areas adjacent to that strictured duct, one may do a sampling and try to identify PANN. But otherwise, I think it's an upcoming area. We need to learn more about EUS and PANN.
Thank you, Surinder. Now, can I just have one comment from each of you as to what message you think we'll be going back with, starting with Rajiv. Just this final 1 minute.
Message is
One message.
One message is balanced solution in acute pancreatitis.
Mohan,
And no ERCP for recurrent pancreatitis.
Roop,
So we need some more molecular studies for translating the stem cells and other business into.
Nilay,
Same with what Mohan says. No ERCP even for pancreatic disease until we get the final answer.
Surinder? Nothing more to add. Okay, finally, we need to use PERT more often in our patients than we do at the present, and that's where we are underutilizing. And of course, the excitement for a microbial source of lipase. I think we'll stop here. Last word from you, Nalini.
No, this is an excellent discussion. Thank you all for giving me this opportunity. I learned a lot. And I agree with Surinder. It's hard to identify pannins. And one of my colleagues, late Mike Levy, told me once saying, it's like taking out the pancreas. You don't take out a colon if you have a colon polyp. So identifying pannin and taking out a pancreas is probably not what we will do. But as you see that technology is catching up, and hopefully it will help us become better clinicians.
We'll sign off from our side. Thank you very much. Thank you, Nagi, Randhir, and the organizers.
Thank you, Naresh, and rest of the panelists. I think it's time for us to start with the next module, which is on IBS. And we have Iman Quigley, who is the regular center in Best of DDW. Iman, as you can see, is a very distinguished professor. He is of gastroenterology and hepatology at Houston Methodist Hospital and holds the chair of David M. Underwood Chair in Medicine and Gastroenterology. He has served as the president of AIG and WGO and has authored more than 1,000 publications. And he's not only a very avid gastroenterologist, he's also very much interested in rugby. And Iman, welcome. And I have the pleasure of inviting our rest of the panel, with Dr. Ramakrishna, Dr. Palniswamy, Dr. Shravan Kumar, Dr. Philip Abraham, and Rajesh Upadhyay. We have a very distinguished panel for this session.
Good morning, everybody.
Welcome, Iman.
I think you're going to show my pre-recorded talk, so. It's a great pleasure for me to be with you today and to talk to you about some abstracts I selected from DDW 2023 on the topics of motility and irritable bowel syndrome. I'd like to begin with just one topic from the esophagus. And this relates to the issue of belching, which is a very common and challenging problem in clinical practice. Recently, belching has been subdivided into gastric and supragastric. Gastric belching typically originating from aerophagia, whereas supragastric belching resulting from air trapped within the esophagus. In this particular abstract, it was clearly shown that you can differentiate between these forms using high-resolution geometry. On the left, a gastric belch shown here is associated with a common cavity phenomenon in the high resolution manometry. In contrast, the supragastric bulge on the left is associated with upper esophageal sphincter relaxation, diaphragmatic contraction, and increased pressure from abdominal straining in the abdomen. The next abstract that I want to mention went further with this issue and looked at the response to behavioral therapy administered by speech and language pathologists in these patients. And what they showed clearly was that this was possible and, in fact, was quite helpful for the patient. And you can see here a list of the various issues they addressed, both triggers to identified leading to belching, and then various maneuvers that they introduced, including abdominal breathing, to help the patient get over this symptom. Moving on to the stomach. So the first issue I want to talk about here is the cyclic vomiting or cyclic vomiting syndrome. And this is a nice illustration of the classical view of the cyclic vomiting syndrome. And it's called cyclic vomiting syndrome because you have episodes of vomiting, shown in the red, interspersed with periods where the individual is symptom-free. It's typically preceded by a prodrome of nausea, epigastric pain, fatigue, and irritability. Then there's vomiting for about 3 to 6 days, and then recovery, and then they feel asymptomatic. Now, as we'll see later, we may need to revise this diagram in more detail. Shows you the various phases of this, the intraepisodic period, which should be asymptomatic, the prodrome, the emetic phase, and recovery. And it also stresses the goals of therapy at these various stages. Prevention during the intraepisodic period, abortion during the prodrome, and to terminate the episode during the actual emetic phase. The first abstract related to this that I want to mention is a study which looked at predictors and outcomes of cyclic vomiting syndrome, looking in particular at the impact of obesity. This may surprise you, but in fact, not only in cyclic vomiting syndrome, but also in gastroparesis, we're seeing a lot of patients who actually are obese. This is summarized here. When they looked at their obese and non-obese patients, there were no significant differences in most parameters. However, depression was much higher in those who were obese, as was female sex. This is quite a detailed study which looked at the natural history of cyclic vomiting syndrome in adult patients in the US, and included in particular a focus on the inter-episodic phase. Now, they looked at the current definition of cyclic vomiting syndrome, which differentiated, of course, between the vomiting phase and the intraepisodic phase, and these were clearly separated with a clear end to the vomiting phase. And then they also looked at demographic and other features. And again, as in many other studies, they found that the majority of these patients were female. They also looked at associated comorbidity. These are very interesting, and they included gastroesophageal reflux, anxiety, depression, migraine, hypertension, irritable bowel syndrome, hyperlipidemia. Very interesting. They then looked at the patient experience over the previous 6 months, and as you can see, the vast majority, over 60%, had at least one cyclic vomiting episode over that 6 months. The remainder either had no episode, which was rare, or they had episodes which did not quite qualify for the definition of cyclic vomiting syndrome. The point they're making here is that we may need to revise this definition based on this observation. They also looked at the average duration of episodes, and this was 7 days in their particular study, a little bit longer than the previous slide suggested. This is another study looking at cyclic vomiting syndrome and looking at a whole variety of parameters, and in particular showing that food-related symptoms and food avoidance are actually highly prevalent in these patients, even in between attacks. And again, suggesting that this nice, neat definition of discrete episodes interspersed with symptom-free periods may not be applicable, especially to all adults. And what you can see here is that particularly those with severe cyclic vomiting syndrome, they had a lot of symptoms and also had very high rates of anxiety and depression, as you can see here. So this is an important observation and suggests that patients with severe cyclic vomiting syndrome or severe impairment of quality of life, even in the intra-attack phase, they had significant intra-attack symptoms, they had altered eating behaviors, and they had higher levels of anxiety and depression. I think this is a very important study. Now, moving on to gastroparesis, and here I'm going to start with the definition that's provided by the NIDDK Gastroparesis Clinical Research Consortium, which has published a lot of data in recent years. So the definition is as follows: symptoms of at least 12 weeks duration, delayed gastric emptying on scintigraphy, and no abnormality causing obstruction in upper endoscopy. Now, the catch here relates to the symptoms, and they include a lot of symptoms, not just typical ones like nausea, retching, vomiting, and fullness, but also inability to finish a meal, excessive fullness, loss of appetite, bloating, and abdominal distension. And when you realize that they include all these symptoms, it should come as no surprise that there's quite a lot of overlap between functional dyspepsia and gastroparesis. And this is borne out by another recent study from this group, where they found that the baseline characteristics and symptom severity are actually identical between functional dyspepsia and gastroparesis. Furthermore, when they followed them for 48 weeks, 42% of the gastroparesis patients now were functional dyspepsia, and 37% of the functional dyspepsia were now gastroparesis. A small group of these patients had extensive histological studies of the stomach, and in both the functional dyspepsia and gastroparesis groups, they found loss of interstitial cells of Cajal and evidence of a pro-inflammatory state. And this, of course, is the treatment approach, which is a stepwise approach, beginning with diet, going on to further adjustments of diet and nutritional support, going on to medications, and then to more invasive methods, including laparoscopic interventions, gastric decompression, etc. Now, what do we find at DDW? Well, the first abstract I chose related to epidemiology. And I chose this because there's actually very little good community data on the prevalence of gastroparesis in any part of the world. And this is a study from Belgium, which looked in primary care, looking at the prevalence of functional dyspepsia and gastroparesis, and basically found that this had remained stable over the 10-year period that they studied, and was at about 1%, which is actually lower than you would expect from the community, which led them to suggest that perhaps some of these patients were actually not being diagnosed. Very interesting topic, namely post-COVID symptoms. In this particular study, they looked at the risk of gastroparesis after a diagnosis of COVID-19. And what they found, basically, you can see here, is that there was about a 1.5 increase in likelihood of developing gastroparesis after COVID compared to a group. This is now looking at this in terms of IBS and functional dyspepsia. This is a meta-analysis looking at over almost 3,000 IBS or COVID-19 patients who are considered for IBS, and almost 1,200 who are considered for functional dyspepsia, compared to appropriate controls. Now, for IBS, overall, there was a 6.3% odds ratio for risk of IBS after COVID, but this actually did not reach statistical significance until they excluded one retrospective study, when this became highly significant, and the odds ratio increased to almost 13. For functional dyspepsia, the odds ratio for developing this after COVID was 8, but here there was a very wide confidence interval, and because of this, it did not reach statistical significance. Now, we all know that irritable bowel syndrome and functional dyspepsia are associated with high rates of anxiety and depression. What this study found, which is surprising to me, was that the rates of anxiety and depression are even higher in gastroparesis compared to functional dyspepsia. At the last time I spoke at this meeting, I brought up the issue of avoid restricted food intake disorder, which is a new component of eating disorders. And this is a study which looked at the occurrence of ARFID among patients with gastroparesis. And they found that positive ARFID symptoms were present in over 80% of patients with gastroparesis, and clinically significant screen was present in 77%. Now, the reason these were positive was because of symptoms related to the appetite subscale, and in particular, fear of aversive consequences subscale. Now, it's how we interpret this is interesting, but at least I think one should be aware of the fact that there may be an overlap between eating disorders and in particular ARFID and patients with gastro. This is a study from India, which looked at a very hot topic, namely this issue of duodenal eosinophilia and its relationship to functional dyspepsia. They confirmed this association and went on to show that it was linked to IgG, not IgE, but IgG-mediated food intolerance, and responded to a combination of fexofenadine, montelukast, budesonide, and a food elimination diet. I want to mention a few technologies, and the first one is this gastric allimetry test, which is also referred to as body surface gastric mapping, which is basically a very sophisticated form of electrogastrography. And as shown here, it involves multiple electrodes placed over the stomach and sensing electrical activity from the stomach. And this can be analyzed with an iPad or actually an iPhone. And here you can see the signal over here, which can be nicely filtered to produce a much more coherent signal than we've seen previously. This was one abstract which involved this technology, and I'll just highlight one issue here. They looked at symptoms developing after a meal, comparing a gastric emptying breath test and the body surface mapping, and found that body surface gastric mapping was much more sensitive to find abnormalities in patients with symptoms of functional dyspepsia or gastroparesis-like symptoms, suggesting this may actually be a more sensitive test for the detection of gastric dysmorphia. It's another new technology. This is a gas sensing capsule which can sense gas content in the intestine as it moves along the intestine and produce a gas profile which can be used to define transit because of differences in gas profiles in various parts of the gastrointestinal tract. And that's exactly what was done in this abstract shown at DDW. This was a study where they compared the SMART pill, which some of you may be familiar with, which has been used to study transit through the stomach, the small intestine, and the colon. And they basically showed that in comparison to SMART pill, this Atmo ingestible gas sensing capsule was equally accurate in measuring whole gut transit and transit within the various parts of the gastrointestinal tract. One other piece of technology is this very fascinating study which looked at what they referred to as magnetically controlled capsule endoscopy, combined with that artificial intelligence to provide studies of gastric motility in gastroparesis and functional dyspepsia. So this idea that you could use a pill cam or a video capsule to study motility actually was first looked at several years ago by Juan Malagenada's group in Barcelona, but these seem to have taken it a step further by combining it with artificial intelligence, and they were actually to show a variety of abnormalities in the symptomatic patients, including decreased contraction frequency and changes in pylorus diameter. Obviously, future studies are required. This could be a relatively non-invasive method of accurately assessing gastric motility in a direct manner rather than an indirect manner, such as using gastric emptying. When we come to therapy, this is one study that I picked out. This is a urocinin NK1 receptor antagonist, dipitant. I hope I've pronounced this correctly. And this was a combination of two studies in gastroparesis, one in idiopathic, one in diabetic. And when they combined the studies, they were able to show a significant response in terms of nausea. But otherwise, I thought this was somewhat disappointing. But nausea is an important symptom and very disabling for some, so this may have some role. A lot of interest in other approaches to gastroparesis, including Botox and GPOM. This is a study from the pediatric population comparing Botox alone to Botox plus pyloric dilation. And basically what they showed was that when you did Botox with pyloric dilation, it resulted in an earlier and more durable response in terms of symptoms in patients with the gastroparesis. Buspirone has been around for some time, for psychiatric reasons, but it also has been used for some time to produce relaxation of the upper stomach. And there was quite a bit of interest in its potential to improve symptoms in patients with dyspepsia through relaxation of the upper stomach and restoration of normal accommodation reflexes. Unfortunately, this study was negative in a population of patients with severe early satiety and postprandial fullness. In a post-hoc analysis, it did improve bloating, but the primary endpoint was not significant. This is one of your local people. This is Sunil Datcha, who's from Hyderabad, who is now the Director of Advanced Endoscopy here with us at Houston Methodist. And he did this nice study to look at the learning curve for gastric peroral endoscopic myotomy. When he was in Atlanta, Sunil was one of the pioneers of this technology. And what they've shown basically here is that using the analysis that they used, that after about 19 procedures, you achieved a high degree of competence. So obviously it takes time, it takes experience, and it takes training. The other interesting approach that is being used widely, both in the esophagus and the stomach, more so in the esophagus, is the use of functional endoluminal imaging, so-called endoflip. And this is a technique which measures compliance and has been used widely in the lower esophageal sphincter to really sort out difficult cases such as postprandial plication dysphagia or esophageal gastric outlet obstruction. So what they were doing here was looking at endoflip in the pylorus. And actually what they showed was that endoflip in the pylorus would predict those who had responded to Botox, in that the responders had a lower pyloric distensibility index, which means it was tighter, and also had some other differences in terms of symptoms. This is very interesting, and it's a relatively easy technique to perform, and of course can be performed through the endoscope. Getting back to GPOEM, this is an important systematic review which looked at 11 studies and included 900 patients looking at the outcomes from GPOEM. And these outcomes look very good. You look at an average decrease of GCSI by 1 point compared to baseline. This is achieved in over 90% of patients, even for up to 4 years of follow-up. Clinical success varied more considerably, but again, here you're seeing some very good numbers and apparently seeing a sustained response. So based on this, it seems that GPOEM is an effective and safe treatment option for patients with gastroparesis, even when followed up for up to 4 years. Now, irritable bowel syndrome. I'll start here with the definition, and in a few minutes it'll become obvious why I'm emphasizing this. So this is the Rome 4 definition, which defines irritable bowel syndrome as recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with 2 or more of the following criteria: related defecation, associated with a change in the frequency of stool, associated with a change in the form or appearance of stool. Now, why I'm emphasizing this and why I'm highlighting the frequency that's defined here will become obvious in a few minutes. But first, I want to mention one study from the Mayo Clinic, which looked at the predictability of bloating for carbohydrate and maldigestion or bacterial overgrowth. And what they found here was that, in fact, bloating was not a predictive symptom for any of these disorders. That's interesting to us because we made a similar observation here in an abstract that we're submitting for the American College of Gastroenterology meeting. Now, a somewhat more complex study. This is from Alex Ford, who will be familiar to all of you from his work in meta-analysis, and he has many studies in functional GI disease. What he's been looking for in this particular study is for a more detailed analysis of patient characteristics and symptoms, which would enable the definition of a more potent prognostic tool for these patients. And what they did using a technique called latent class analysis was they identified 7 clusters of individuals based on their dominant symptoms and based on their symptom severity and based on their psychological burden. And what they then did was looked at, could these clusters predict impact and burden and outcome? And the answer is yes. And up the top here, I've highlighted these clusters here, all of which had a significant psychological burden and all of which were associated with the worst outcome in terms of quality of life. And this is highlighted here, that this cluster 6, which had this high psychological burden and high symptom severity, had the worst outcome. So we may be working towards a more detailed assessment of patients in terms of subgrouping and moving away from just looking at whether it's diarrhea predominant or constipation predominant, but actually looking at a more detailed analysis of symptoms, symptom impact, and psychological comorbidity. Now, I was involved in the Rome multinational survey, which has been the first comprehensive survey of symptoms of gut-brain disorders, and which of course included India. And in this study, one of the surprising findings was the relatively low prevalence of irritable bowel syndrome as defined by Rome 4 and in comparison to Rome 3. And this, of course, gets back to what I said earlier about the definition of irritable bowel syndrome. Because there was a change in the frequency threshold from Rome 3 to Rome 4, and also because the term discomfort was dropped from Rome 4, this resulted in a significant fall off in IBS prevalence. So that whenever you're looking at a study on irritable bowel syndrome, make sure you understand what criteria were used to make the diagnosis, what was the sex distribution of the population, and what was the age distribution. And I stress the latter because, of course, throughout the world, females are more likely to have irritable bowel syndrome, and those who are older are less likely to have irritable bowel syndrome. Now, this was looked at in much more detail by Magnus Simran, who looked at a whole variety of variable ways of looking at symptom frequency and how this affected IBS definition. And what they found basically was that of all the various permutations and combinations, changes in the frequency threshold of abdominal pain and discomfort has the most prominent effect on IBS prevalence. The higher you set that threshold, the lower the prevalence. But even if you employ less strict criteria, you will still identify a group of IBS subjects who will have impaired quality of life and increased healthcare utilization. So this answers one question that I always had. So if you went from Rome 3 to Rome 4 and you lost a whole lot of IBS, what are the ones who dropped out? Are they not IBS anymore? The answer seems to be here. They actually are still IBS. This is a fascinating study, which some of you will have seen in previous work. And this is using confocal laser endomicroscopy to provide a live assessment of the impact of various foods on the intestinal mucosa. What they did here was they exposed individuals with irritable bowel syndrome to the following foods: fish, nuts, egg white, soy, milk, and wheat in a randomized fashion. And then they looked at changes in the mucosa using CLE, and they also measured thymus secretion in vivo and also took biopsies to measure permeability using inosing chambers. And what they found, firstly, was that there indeed was a high rate of sensitivity to these foods. Now, before we look at the data here, it's important to stress that all of these patients had been negative on food-specific IgE testing. Despite this, 57% were positive for wheat, 38% for egg, 44% for milk, 23% for fish, 33% for nuts, and 14% for soy. So they found a high rate of acute mucosal reaction in these non-constipated IBS. But these were not linked to changes in mucosal permeability or chymase secretion. So obviously we need more data to explain exactly what is going on. This is another study from Magnus Simran's group in Göteborg in Sweden, looking at another very interesting issue, namely methanogens. As you know, it has been suggested that methane production in the gastrointestinal tract is associated with constipation and in constipated variety of irritable bowel syndrome. They looked at methanogens in irritable bowel subjects and in controls, and found that actually the prevalence of methanogens was similar in IBS and controls. However, in IBS patients that had methanogens, they were more likely to have constipation and bloating. They were also more likely to have delayed colon transit. So suggesting that while methanogens may be no more common in IBS than controls, if they are present in IBS, they do affect symptomatology. This is a very detailed study from the Mayo Clinic, which looked at post-infectional irritable bowel syndrome, and in particular, irritable bowel syndrome following Campylobacter infection. And what they found was that this infection, or this post-infection irritable bowel syndrome, was accompanied by changes in intestinal permeability, and also in changes in gene expression, changes in transcriptomics, and in the prevalence of molecules such as histamine, which seem to be linked to the development of impaired epithelial function. This is actually a clinical trial of a food intervention in patients with irritable bowel syndrome with constipation. So this was a randomized, double-blind, placebo-controlled study which evaluated the efficacy and safety of a food containing xyloglucan, pea protein, and chia powder. And what they found basically is that in comparison to placebo, this particular foodstuff resulted in a significant reduction in abdominal pain, in bloating, and in constipation. So another example of a foodstuff being associated with significant impact in irritable bowel syndrome. There have been several studies looking at fecal microbiota transplantation in patients with irritable bowel syndrome, and I think it's fair to say that the results have been divergent. Some positive, some negative, some actually even making people worse. In this study, they actually did a very neat study where they took patients with irritable bowel syndrome and they randomized them to receive either placebo or FMT either by an enema or through in capsules. And what they found basically in looking first at the IBS symptom severity score was that this decreased significantly in both the enema and the capsule group in comparison to the placebo group. And this was accompanied by significant improvement in quality of life and significant reduction in abdominal pain. This is very interesting and suggests that capsule administration, which of course is much easier, may be effective in irritable bowel syndrome. Now, just a couple of disorders I want your attention to, which I'm not going to discuss in any detail, I just want to mention them. First is one that causes a lot of problems for me in clinical practice, namely superior mesenteric artery syndrome. This is an interesting abstract, which I'd invite you to look at in detail, which compares the presenting features between younger and older people with superior mesenteric artery syndrome. I think I have still major questions about the diagnostic criteria for this condition and on outcome, because we really need good, well-controlled data on interventions in this disorder. This is a very interesting paper, which is experimental, which is looking at the induction of Parkinson's disease in an animal model, taking it from the gut. As you know, there has been this hypothesis that Parkinson's disease may originate in the gut, and they're suggesting that actually this can be done in an animal model. Finally, this is a very interesting paper. It's actually not from the motility area. It's from Crohn's disease, showing the interaction between the microbiome, the gut, and the brain, and how this can be evaluated using very sophisticated imaging technology, but basically providing further evidence for this important interaction between the microbiome, the gut, and the brain. So in summary, firstly, I think we have data which will help us to differentiate gastric from supragastric belching, and also information to suggest that this can be treated with speech-language therapy, directed behavioral therapy. Cyclic vomiting syndrome has a variable presentation, may severely impair quality of life, and may exhibit features of ARFID. In primary care, the prevalence of functional dyspepsia and gastroparesis is about 1%. COVID may result in gastroparesis and irritable bowel syndrome, but maybe not functional dyspepsia. Gastroparesis is associated with psychiatric comorbidity and ARFID, and duodenal eosinophilia and functional dyspepsia seems to be related to IgG-based food allergies and response to an anti-inflammatory, anti-allergic cocktail. The elementary body surface gastric mapping technology may be used to study gastric physiology and dysfunction. The atmodynamic gas sampling capsule can measure gas transit or gut transit and gas production. The latter, of course, might be helpful in detecting bacterial overgrowth. The magnetically controlled capsule endoscopy approach assesses gastric motor function, and confocal laser endomicroscopy can detect food reactions in IBS, which are not apparent by more conventional means. Bloating does not correlate with carbohydrate maldigestion in IBS. New symptom clusters predict quality of life impact, medical care use, and outcomes in patients with irritable bowel syndrome. Diagnostic criteria for IBS impact on prevalence. Methanogens are associated with symptom patterns in IBS, but no more common in IBS than controls. And distinctive permeability changes, transcriptomic findings, and immune modulator changes seem to be evident in post-infection irritable bowel syndrome. I've illustrated one new food-based therapy for IBS, and I've also shown a study which illustrates a new vehicle for the effective delivery of fecal microbiota transplantation in IBS.
Thank you, Dr. Quigley. You obviously covered a wide spectrum of conditions affecting mainly the motility in the GI tract and not restricted yourself to IBS. Right from the upper GI tract, we've come down to IBS and seen the whole spectrum of not just motility conditions, but also food allergies and their impact on the gastrointestinal tract. We have a panel of experts here who will give us their viewpoint on the Indian perspective. In addition, I would request people from the floor, the delegates, to raise points or to raise any questions that you have to Dr. Quigley before we go down to the panelists. Any burning questions from the delegates on the floor? Any clarifications you need, Mishra? Shiva?
My question, Dr. Quigley, is on the paper regarding confocal endoscopy and looking at the mucosal reactions of various foods. Now, there were 6 foods tested, and all of them showed about 30 to 40%. But where is our control group? What about foods which are considered inert? We don't have a comparative group to say what would be mucosal reaction, at least as far as I could see from that abstract, to other kinds of bland foods, what are considered bland foods. Do we have any data to that? Is it only for these kind of potentially allergenic foods that the reaction occurs, or is it when we don't have a comparator group, how do we come to that conclusion?
Yeah, that's a very good point. Now, this particular group and other groups have looked at a variety of foods. Initially, they were particularly looking at gluten in so-called non-celiac gluten sensitivity. There are control studies, and they do compare them with so-called what you refer to as inert foods. The foods they chose were ones that are commonly implicated by patients as causing problems. And I should emphasize that all of these patients had conventional IgE antibody testing, and they were all negative for those foods. So the foods were selected based on clinical experience with these foods causing reactions. And yes, there are controls for these studies on which the changes are based.
Thanks, Eva. Naresh here. Like your comments on this IgG antibodies and duodenal eosinophil, various foods. What is the criteria? How many eosinophils are sick? When do we start working on them? And this entity real?
Yeah, this is a very, very interesting area. So there are 2 controversies you brought up here. The first is the IgG antibodies. That issue has been around for a long time. There were studies 20, 30 years ago, which suggested that in patients with IBS who had complained of food intolerance and who had negative IgE antibodies, that a substantial number had positive IgG antibodies, and that food elimination diets based on IgG antibody profiles were helpful. This was not supported by subsequent studies. So I think the IgG antibody story is interesting. We were just involved in a multi-center study here in the US that looked at this. It's not been published as yet. It was negative. It did not find that IgG antibodies were predictive of response to a diet, an elimination diet based on foods identified in IgG. Now, with regard to duodenal eosinophilia, I'm not a pathologist, but I do know from talking to our own pathologists that there are concerns about how exactly you count these. As you know, a high power field sounds as if it's an objective criteria. It's actually not. And so how you define a high power field, how exactly you count eosinophils is important. The various studies, particularly the ones from Australia, have provided criteria. I can't remember what the numbers are for the duodenum, but there is an issue about control here, about controls and exactly what is significant. But it's very interesting. You know, we do a lot of biopsies in the duodenum and elsewhere in patients with dyspepsia, and we don't see this. But there are a couple of groups, not just in Australia, but also the Antax group in Belgium, have also reported increased eosinophils in functional dyspepsia. But I think we need a lot more data.
Thanks.
Sure.
Good morning, Professor Quigley.
Good morning.
FMT is becoming a panacea for everything. Do you think it really works in IBS? Number one. Number two, there's a saying, in Rome, do as the Romans do. But Rome criteria is being applied to the entire universe. Yes. It's very diverse, you know, definition. I still feel that the Manning's criteria of 1994 does well for India.
It does well for everywhere. It's, you know, if you think about if I think about what I do in my clinical practice, it's really Manning criteria.
Then why worry about Rome?
I think Rome 5 is underway, and it will be finalized at the end of this year and published next year and the year after. And I think Rome 5 will go back to something closer to Rome 3. I think Rome 4 has been overly conservative and has eliminated a lot of patients who really do have IBS. So I think that's a very important point. As regards to FMT, that's a very interesting question. The studies in FMT are all over the place. As I mentioned, there are some positive studies from Norway. There are negative studies from Norway and from elsewhere. What seems to be very important is the donor. We don't know what it is about certain donors that are important, but the Norwegian studies which have been most positive, which are using conventional FMT approaches, use what they refer to as a super donor. And they have like 80% response rates. They're sustained for 1 year or 2 years. And we've never seen changes like that in IBS. So I think there is something there. But FMT is such a complex therapy. There's so many bacteria involved in it that we really don't know what are the active moieties. I think we will find out, because people are working on that. But I think there is something there, but at the moment you could not recommend FMT for the treatment of IBS because you don't know really what.
Yeah. You extensively covered topic of gastroparesis talk, and the burning question we face is how to identify patients in whom pyloric directed therapy are going to work, like the upcoming TPOM and even Botox. You mentioned one of the paper in which endoflip was helpful in predicting response to Botox. So can this endoflip readings are now standardized, and can they be used in clinical practice?
I would say there are two problems. First of all, do endoflip in the pylorus. You need that. I can't remember the name of the scope, but you'll all know it's the scope with the really big channel. Because like in the esophagus, where you can pass the endoflip catheter blindly and you keep it in position blindly, you can't do that in the pylorus. So you have to direct the catheter across the pylorus using the scope. So you have to have this mega channel scope. Now we're fortunate that we do have it. And actually, Sonal Datchung, who I mentioned, is looking at this very, very particular issue. You know, can endoflip measurements predict response to pilot? There is some data to suggest that it does. There's a French study and also a study from Atlanta, but I think the studies are still small. Are there clinical criteria that allow you to predict response? we've not got there yet. Gastroparesis is a very complex condition. It's a condition I'm very worried about. I think we diagnose it far too easily here in the US. And I think it includes a whole variety of people, from people who really have severe psychiatric problems on the one hand, people who have a significant organic disorder based on impaired muscle and nerve function on the other. So we're still in early days here. Sunil is doing a lot of GPON here for us, and we're prospectively looking at that data, and hopefully we'll have some results possibly for DDW.
Thank you.
But I wouldn't recommend doing any flipping clinical practice in the pilot. Excuse me.
All right, so we've covered a few questions from the audience from the Indian perspective. Now let's pick up the brains of our panelists here and take a look at the Indian perspective. We'll start from the very beginning when we talked about belching, supragastric and gastric belching. And we've always thought of gastric belching as a release from a pressure cooker, and supragastric belching as a psychiatric disorder where you can see the patient doing his aerophagia act and then having the belch. But there's one thing unique, I believe it's unique to India, and that is these trigger points that we have in patients with belching. You know, whether it's from Kashmir or Kanyakumari, they all talk about press me here, press me there, and I can belch. And they can demonstrate that for you. Any comments or any ideas on why this is happening? Is it part of the meridian system that the Chinese talk about, or is there something more to add? Rajesh or Avan?
Most of our clinical practice, we come across such a belching is a commonest functional disorder. Most of the times we feel that it is a psychosomatic issues. Those people are more of anxious and anxiety disorders. They do come with all such kind of belching disorders. So clinically, we see that such people, we don't expect such any organic cause in these patients. The only thing is we have to look into the matter for how far they have been under the background of the story about the stressful factors, maybe the underlying stress issues. They may be come across with such a stress issues. We have to relieve by giving such a kind of the support, and clinically we have to give them assurance and maybe some kind of the treatment which are being better for something like patients really have any kind of the stress factors which are been causing such things. So I can take the Dr. Ramakrishna sir, whatever he says.
So during the COVID pandemic, I found an explosion of patients with supragastric belching, atypical chest pain. A lot of people coming to ER. I expect it was that time when we were all confined to our homes and fear complex. So from what I understand, Dr. Quickly, what you're saying is that we need to use impedance and resolution barometry to differentiate gastric and supragastric belching, essentially because it would guide treatment. Is that what you're saying?
I think in clinical practice you can differentiate them. There's a much simpler way. As I mentioned, gastric belching is associated with aerophagia, so you can get a plain abdominal X-ray, and you will see the gastric bubble in patients with aerophagia. And the other thing is that at least I see a lot of these patients, and they will belch so frequently that you will see their belching pattern when you're sitting with them, and it'll become clear. You're absolutely correct. The supragastric belchers are the ones who are more likely to show up with chest pain or chest discomfort, because their esophagus is becoming distended by this trapped air. And it does become it's one of these learned illness behaviors, and that's why I was so interested to see some data. It's not great data, but some data suggesting that behavior modification will work, because that is the only treatment. You can try baclofen, particularly in the gastric belchers, with some success. But I've seen some of these patients who are extremely incapacitated by this symptom. And for those, I think I've tried hypnotherapy. It's very hard to find speech and language therapists who can actually do behavior modification therapy for these, and it's a great need.
So does Dr. Quigley suggest that belching is per se a physiological abnormality, or there is a psychological component to it?
Well, actually, belching is a normal reflex, which mediates the vagovagal reflex. So it's a normal reflex. When these individuals, it's become exaggerated either because of too much air in the stomach from swallowing too much air, or because of air trapped in the esophagus, which is, but the psychological component here is very significant.
Do you also see in your country these trigger points that we see in India? Many of them, these common trigger points that they all have, you press at different places and they can belch on demand.
No, I haven't come across that. It's a very interesting idea. But I at least in the patients I've looked at, they haven't as yet identified trigger points. I wish they had.
Philip, can I think this is a kind of a condition thing that if you look at our traditional thing of Vata, Pitta, and Kapha, as in Ayurveda, so this whole thing of gas is supposed to be related to Vata, and Vata is related to problems of joint. So they press that joint, and that gives rise to some gas. And they see their grandmothers start doing it, and as they grow older, they start aping the same.
So physiologic or psychologic?
Conditioned.
I'll have to go back and check what that means.
I feel it's more of a psychological than the logic. Recently,
Quick show of hands.
psychological.
Psychological.
There we are. So there's no role for impedance, no role for a speech therapist. What he needs is a shrink. No?
I routinely refer my patients to a speech.
All right, we'll move now to cyclic vomiting syndrome. How often do we see that in clinical practice? Endoscopy is available at every street corner. PPI, H2RA are given for cough and cold as well. So maybe we are missing some of these patients. We're treating them all as organic conditions, acid peptic conditions. How often do you diagnose cyclic vomiting syndrome in your practice, Rama?
Cyclic vomiting syndrome is something we do see, not uncommon. It's very common. Certainly not uncommon. We able patients. And in my mind, always has been spectrum of migraine disorders, or whether it's purely a GI motility problem or a metabolic problem. Sense that originally we were taught when accumulation of proteinaceous metabolites in your body, and during the period that you vomited, you would avoid food. These metabolites would nutrition. Presumably in children, some children, but yes.
So you would make the diagnosis only after you've given them a trial of antiacid, sent them through an endoscopy.
Cyclic vomiting
or...
syndrome, I wouldn't give no role for it.
No, there isn't any role, but do we make a diagnosis in clinical practice?
Cyclic vomiting syndrome, to me, is very clear. They come and tell you that there's no doubt. They don't have, although Dr. Kwekli showed that there may be inter-episode symptoms, it's not that common.
Could I emphasize that you're absolutely correct. First of all, cyclic vomiting syndrome is not rare at all. And you're absolutely correct, Mr. Chairman. It can be diagnosed clinically. You shouldn't need to, because if you take a history and take a history well, you should need no test. The problem is, as the paper that I showed illustrated, in patients with severe cyclic vomiting syndrome, they may transition to more or less persistent symptoms. That's the problem. And as you mentioned, as your panelists mentioned, it's commonly associated with migraine, and it behaves just like migraine. In fact, you can use migraine therapy to treat these. So just like migraine, you've got severe episodes of migraine, then you feel fine, and another episode of migraine. So it's very in the classic example, which is the most common form, got stereotypical episodes with normal periods in between. You don't get that with gastroparesis or with other.
In fact, so Philip, the medicine that I use most commonly is Electrophyisiology.
Yes.
I also agree. I think we can make a diagnosis clinic cyclic vomiting syndrome, but we end up doing all the investigations possible.
Yeah, that's the point I was trying to make, that yes, it is a distinct condition, yes, but how often do we make that diagnosis clinically without putting the patient through these steps?
I'll tell you, in my own practice in Delhi, I've seen a number of these patients. Most of them have been females and young females. And they often come with this typical history. Usually, they have not had the abdominal pain a part of it. And as Dr. Ramakrishnan was saying, sometimes you wonder whether this is a variant of the migraine syndrome. If it is predominant vomiting, I call it cyclical vomiting. If it is predominant headache associated with the vomiting, then it probably may be moving towards migraine. But treatment-wise, we have used different types of antiemetics. But I must say that drugs like prochlorperazine is something which I have used very frequently with success. Most of these patients have got associated anxiety and depressive disorder as well. So sometimes you have to get the help of your psychiatric colleagues.
So we generally see such kind of cases in children, basically from the adolescent age or less than adult age, less than adolescent age, maybe around 8 years to 10 years or 12 years, that age group, they come across with such kind of frequent vomitings. Immediately, whenever they take intake of food, they vomit out. So without any gap in between that, they immediately vomit out without any pain abdomen. So usually, if you take a history, most of the children, they have been transferred from one school to other school. Those they lose of their fellow friends. So when there is a companionship is lost, so those the children they think that they're all very much lonely, and the less parental attraction to the patient children. The children, those who are not being taken care of much by the parents, those children they have such kind of psychosomatic issues. So those are the children they come across with frequent cyclical vomitings. So probably we can give the assurance to the parents. This is the more of parental syndrome than the children's syndrome. So parents are more anxious. They're coming across and frequently showing the number of doctors again and again. In spite of investigating many of these children, there won't be any kind of significant, any kind of the positive issues in the children. So only thing is, over a period of time, everything they become all right. Only thing, they will not have any loss of weight. They will not have any kind of systemic disorders. The only thing, the assurance to the parents and assurance that the children should get the proper, the friendship of the children is very much required in order to maintain the psychological balance of the children. That is what we feel.
Just two comments. One is that I agree on migraine, use a migraine kind of pattern, stereotyped vomiting thing, episodes as a kind of to guide us to make a diagnosis. Two is that we do see it in adults. I think we must be careful about cannabis, something that mimics cyclical.
Both very important points. The point I was only making is that awareness of CVS seems to be less in the medical fraternity. And you can see that most of these children have been subjected to unnecessary investigation before you can confidently make a diagnosis of cyclical vomiting. But the criteria are so stringent that it should not be difficult to make a diagnosis without having subjected them. Because many of these children are the ones who have a reason for school absenteeism. And that's when they come to attention of the parents. Moving on from there to gastroparesis and functional dyspepsia, how often have you made a diagnosis of primary gastroparesis outside diabetes and in the post-op state?
Very uncommonly, but I must say that during and after the COVID era, I've seen one or two problem patients who had clear-cut gastroparesis, which went on for more than 3 months. They were very difficult to treat. There was a background of psychiatric issues as well. But outside the diabetic and the post-op, I think the viral is the one which I.
Remember, originally the gastroparesis, syndrome of gastroparesis, not talking about diabetics, primary gastroparesis, was originally described as women with persistent vomiting. Many years ago, when I think you do see a lot of patients in whom I make a diagnosis. But it's really quite different, quite difficult to differentiate from functional dyspepsia. We do the gastric emptying studies. Sometimes there are issues with the way gastric omits the get a false value gastric half empty time. So change. And we are now doing electrophysiology as well, which I'm not very clear how we Quigley's opinion. It's been quite difficult.
First of all, from what you're saying, it sounds like Indian gastroenterologists are a lot wiser than the gastroenterologists in the US, because I think we grossly overdiagnose gastroparesis because we do far too many gastric emptyings. And that's a major concern of mine, because I think once you make the diagnosis of gastroparesis, and I think I mentioned this last year, then that label never goes away. And if they don't respond to medication, the next thing is they're having gastric pacer placed, they're having pyloromyotomies, and it goes on and on and on. And I've a large cohort of patients who are severely impaired with the diagnosis of gastroparesis, and I don't think gastroparesis got anything to do with their problem. They've got psychopathology, they've got a whole lot of other things going on. So that really concerns me. I mentioned the elementary system specifically because this system was developed in New Zealand, and I was in New Zealand at the New Zealand GI Society last year, and I actually met with a group of investigators there who'd worked with it. It's a very simple technique. It's not cheap, but it's a non-invasive technique, and they have a lot of confidence that it can detect organic disorders of the stomach, and they've actually been able to take people off TPN, take out PEG tubes, like be able to tell the patient, look, your stomach motility is normal. This has got nothing to do with gastro. We need to address it. So I'm excited about this. We hope to get a system in place here very soon, and I know the number of centers in Canada and the US are already using it. So I think gastric emptying testing, you're absolutely correct. It needs to be done correctly. But that has been standardized, and there is a standardized and validated protocol. But I'm not sure that it tells you very much. Because in the patient with type 1 diabetes with established gastroparesis, you don't need testing. It's obvious. You see a big BSOR when you do it. It's the idiopathics, and the question of the chair is absolutely appropriate. When you deviate from diabetes and post-surgical gastroparesis, I think you've got to be concerned. But I think the interesting one is the one that you also mentioned, namely the post-viral group, who are interesting. They're not very common, but they are an interesting group. And of course, we do know from a variety of studies that viruses can directly impact on the nervous system, and they can reside there for a long time. So I think my overall message to you about gastroparesis, be very, very careful in making. And you seem to be doing the right thing more so than we are.
Thank you, Dr. Quigley. That makes us feel good. And in the data that you presented, about 40% of patients had interchangeable diagnosis. At a 48-week follow-up, their diagnosis changed from functional dyspepsia to gastroparesis and the other way around. Coming to our Indian panelists, we don't have IV erythromycin in the country, not freely available. What are the options for treating gastroparesis then?
Unlike in the USA where it's only metoclopramide, probably prucalopride these days, we have a whole array of prokinetics. And in fact, metoclopramide, particularly in the elderly or those with renal failure, I'm a little reluctant to use. So the use of domperidone itself is probably been, we've had the longest experience. But in gastroparesis, the dose of domperidone, which can be used, is almost double at least of the standard 10 milligram 3 times a day. The one which I use more commonly these days is etopride, for which there are a number of studies as well. it has got a relatively low level of side effects as well. And so that is something which I have as a choice. Levosulfuride seems to be another very good option, except that we are all aware of some of the side effects of levosulfuride, particularly when you use it for a longer period of time. But especially in those patients, because don't forget that levosulfuride came into practice from the psychiatric side. It was used initially as an anxiolytic drug, etc. So in patients who have got a background of anxieties and they have got gastroparesis, I use levosulfuride as well.
So effectively, we talk about using the standard prokinetics in oral formulation in these patients. Levosulfuride is, of course, available as IV preparation as well. Moving on from there, because we don't have much time, to food allergies. And there was this study that came from Mumbai where they talked about food allergies being quite rampant and changes in the duodenum. And then there was a study on IBS where again they talked about changes in the gut on exposure even when the other tests are negative. So are we overstating food allergy? Is it now prime time for us to use Montelukast or steroid when the standard drugs don't work? Or we still need a lot more data?
Probably we should start looking for the food allergies, and then maybe in case you prove the diagnosis, you may have to use the Montelukast and steroid.
Dr. Quigley probably had his reservations about this.
Yes, I think this is a very interesting area. There's a lot of talk, as you know, about so-called non-celiac gluten sensitivity. It's probably better called wheat sensitivity, which is where a lot of this started. I think we need more data, and we need more prospective studies, which include not just demonstrating a response, an IgE or an IgG-mediated response or a CLE response, but actually then going forward and using diets based on those results and showing that they have an impact. So I think the Mumbai study is very interesting from that point of view because they did use an intervention. Now, unfortunately, their intervention basically covered everything. So it's hard to know exactly what components of their cocktail were the most active or actually active at all. So I think we definitely need more prospective studies because patients ask about this all the time. I'm not sure what it's like in India, but the patients I see, they're convinced they've got all sorts of food allergies, and most of the time, of course, they don't have food allergies, they have intolerances. And there is no shortage here of companies in the US which will test blood, hair, you name it, and tell them that they've got all sorts of allergies, which is totally. But so it's a very controversial area, and it's a very problematic area to deal with in terms of patients. I'm not sure whether that's going on in India or not, but it's a big problem here.
I'm ahead of you on that.
So the paper Shobna's group, not food allergies typically would be,
right.
And this
Right.
was IgG-mediated tolerance, which don't go into the general classification. IgG-mediated intolerance is used by lifestyle medicine practitioners to tell their patients that, your depression, your loss of function. So this is different, and this is something that we don't understand. I think we need to go a long way.
All right, we're running out of time, and we obviously cannot cover all the topics that have been covered in this wide spectrum that we heard this evening. Just two quick yes or no answers. Number one, we talked about the female predominance in IBS all over the world, but we somehow don't seem to see that in Asia. Is that only a cultural difference, or there's more to it? And number two, the same question that was brought up earlier, how many of us use any of the Rome criteria for diagnosis of IBS? Does it only keep the experts busy? We're going from Rome 1 to now Rome 5. And in clinical practice, how many of us use the Rome criteria? Or when the patient walks in with his database, you already made a diagnosis of IBS. Can we have a show of hands? How many of us use the Rome criteria in clinical practice? Well, I'm glad Dr. Quigley can't see this, but hardly 10 hands have gone up. The denominator must be 200.
Philip, in answer to your first question, the female predominance. I mean, the male predominance. If you saw the map that Dr. Quigley showed, India was marked in yellow, which was a household-based survey. Household-based survey also showed that there was a female predominance, not a male.
Correct.
All right. Thank you so much. We could go on and on discussing this, but we're running out of time. So I thank all the people from the floor who raised questions here. Thank you, Dr. Quigley, for a wide spectrum of coverage that you gave us and the panelists.
Thank you, Philip.
Thank
We
you
had
for
two
having me.
very interesting, and we have a 15-minute break. We'll come back exactly at 5:45 for the hepatology session. Patrick.
Hello, check.
Hello, can you hear me?
Yes, sir.
Am I clear? And
Yes, sir. Your audio is clear.
good. And you can see me also. Good. So I'll leave this position.
Good evening, sir.
What's
Sir, we'll
that?
have a tea. We have a 15 minutes tea break, so we will.
Yeah, that's
So we will come back at 5:45 exactly. Sir, you will be presenting from there, or we will play your video.
no, I'll present from here.
Acha, you want to present? Okay, fine, sir.
Hello, check. 1, 2, 3, 4. Hello. Check. 1, 2, 3. Hello.
Hello.
Hi, Nagi.
Start our last, and I think we have to start exactly in time because Patrick, in spite of a social commitment, need to stay back. Patrick, thanks a lot. We've had two very interesting sessions. Come to this now. Patrick Kamath, everybody knows the clinic. He's been leader of Hepatology, responsible for the health score, and was been editor for many. Recently voted as the teacher of the year and distinguished educator from many. He'll be doing the session, and I request our Indian panelists. P.N. Rao is already there. I have Dr. Harshad Mithun Sharma from A. Parimal Lavate from
Dr. Konar from Kolkata.
So Ashok. Yeah, Ashok Anand, Calcutta. We have a full panel of hepatologists here, Patrick.
Thank you very much, Nagi, for that kind introduction, and really honored to have my teacher, Dr. P.N. Rao, chair this session. Also good to see that Harshad, one of my former residents, is also in this session. So I will go over best of ASLD at DDW. I'd like to thank all the speakers who shared their slides with me, and I'd like to congratulate them for their work. So in this talk, I'll try and go over abstracts related to NAFLD and hepatic fibrosis, some talks on cirrhosis, some miscellaneous topics, and most important of all, the take-home messages in case you missed many of the abstracts in between. So this paper is from Richard Sterling and the HIV. This is an NIH network which is studying NASH in patients with HIV. I've taken this to discuss in a little more detail because I thought if you're going to do a study, this is the sort of methodology that you need to work on. So there'll be some terms which I'll try and explain here. So the question, ask yourself, do FIB4 and NAFLD fibrosis score have high positive and negative predictive value to determine the presence of hepatic fibrosis in patients with HIV-related NAFLD? Okay. And we'll see whether we can answer this question in this abstract. So NAFLD is common in patients with HIV. And so those are called PLWH, or people living with HIV. So NAFLD is common in that group. Previously, mortality, when HIV first came on, mortality was related to AIDS. Then once drugs were available to treat HIV, patients died of hepatitis C complications. Now we can treat hepatitis C. So the question is, are these going to be patients who will die of fatty liver disease? And so it's important to identify advanced fibrosis in this group. So non-invasive testing, all the non-invasive tests that we have for NAFLD have been predominantly in patients without HIV. And the ones that have been used are the FIB4. The FIB4 has been put together by Richard Sterling. He's the first author of this abstract. The NAFLD fibrosis score was put together by my colleague, my late colleague, Paul Angulo, and the liver stiffness measurement. Okay, so these are the three, and so these are the three that are basis for the study. So in NAFLD, fatty liver disease gives rise to fibrosis, and that in turn gives rise to cirrhosis. So what causes these? There are host factors, there are HIV-related factors, and there are HCV-related factors. And terminology, INSTI is integrase strand transfer inhibitors, and NRTI is nucleoside reverse transcriptase inhibitors. And we know these are associated with weight gain or redistribution of fat. So the aim of the study was to determine the performance of FIB4 and NAFLD fibrosis score in patients living with HIV and NAFLD. specifically to identify those with advanced hepatic fibrosis. The prospective study from 8 centers, liver stiffness measurements were taken. Stage 2 defined as liver stiffness greater than 8 kPa and 3 greater than 11.3 kPa. So FIB4, age times AST, platelet, and ALT. NAFL fibrosis score, a little more complicated, includes diabetes, age, and albumin in here. The inclusion criteria, adults, HIV under control, so RNA had to be less than 200, and they were on stable CART, that's combination antiretroviral therapy for greater than sigma. So stable HIV, and excluding those who had comorbidity, other liver diseases that could change stiffness, or in those whom HIV was still active. The descriptive statistics we used, primary outcome was liver stiffness primary outcome was F2, F4, liver stiffness greater than 8 kPa, and F3, F4 is greater than 11.4 kPa. I'm going to explain these terms in a bit. Operating characteristics were sensitivity, specificity, positive predictive value, and negative predictive value for the different cutoffs. That's less than 1.3. You know, in India, the guideline says 1. In the US, it's 1.3 and greater than 2.67. And an NFS score of minus 1.455 to rule out fibrosis and greater than 0.675 to indicate that the patient has more advanced fibrosis. And the area under the curve, which again I will explain in a bit, for FIB4 and NFS was calculated. So these are the terminologies that are important. So you'll see it in a lot of papers. I thought I'll explain them in a bit. So what is sensitivity? You use the term sensitivity and specificity when you already know the diagnosis. So sensitivities, you say, I know my patient has the disease. What is the chance that the test will show that the patient actually has? Specificity is, you know your patient does not have the disease. The question is, what will the test show that, what is the chance that the test will show that the patient doesn't have the disease? Okay, so use sensitivity and specificity when you know the diagnosis. If you don't know the diagnosis of the patient, the terms used are positive predictive value and negative predictive value. So positive predictive value, I got a positive test result back on my patient. What are the chances that my patient actually has the disease? Negative predictive value is I got a negative test result on my patient. What is the chance that my patient actually doesn't have the disease? Okay, so because we're going to be using these terms in the discussion here. So sensitivity and specificity when you know the diagnosis, positive and negative predictive value when you don't know the diagnosis. So these are the characteristics. If you note, this is a US population, so BMI and weight circumference, on the heavy side. CD4 counts were okay. Liver stiffness measurement greater than 11.4, only in about 5% of patients. Again, important to know, study is best when there are many endpoints. When there are only a few endpoints, so 5%, you always wonder how good the study is. XOL is cholesterol, so you can see the lipid profile here, HbA1c, liver tests, alkaline phosphatase, platelets, all close to normal. Remember I said greater than 2.67, only a small percentage of patients, 4% and 7% based on the score. So let's go to true positive, true negative, false positive, false negative, okay? So these are the results that they show, but now you don't know whether the patient has fibrosis or not, okay? So sensitivity and specificity is if you know it. Positive and negative predictive value is if you don't know it. So sensitivity and specificity, you knew the diagnosis, not very good at this threshold. Specificity better than sensitivity. So at 2.67, it means If you get a value greater than 2.67, good chance, if you get it less than 2.67, very good chance the patient does not have advanced hepatic fibrosis. If you look at the NFS threshold, here you can see that your specificity again is about 90%. So these tests are good to rule out advanced hepatic fibrosis, not so much to rule in significant hepatic fibrosis. So the same thing you see here, negative predictive value of these tests is good. So we come to the second part of the assessment, which is area under the curve, which I'll explain again. So they use the area under the curve first for liver stiffness measurement greater than 8 kPa to find out whether this is F2 to F4 fibrosis. So the area under the curve is calculated by plotting the sensitivity on the y-axis and 100 minus or 1 minus specificity on the x-axis. So really this point is 100% specific but 0% sensitive. So this is how you interpret area under the curve. Again, important, anytime you read a paper, what does area under the curve mean? So area under the curve looks at different points on the curve and it looks at two numbers. So for instance, which you might understand a little better, is like take MEL score. Take two pairs, MEL score 20 and 21, then 21 and 22, 22 and 23. So take 10 such pairs. How often is the patient with a higher score more likely to die than the patient with the lowest score? Okay. So if it is 10 out of 10 times, that's an area under the curve of 1. No test ever can give you that value. So here's how typically you get the area under the curve. So 5 out of 10 times, person with a higher score dies before the patient with the lowest score. That's just by chance, flip of a coin. So that's not a good test. 0.6, you say, yeah, I think there is something here. It's still not good enough for clinical use. So 0.6 and all don't use for clinical decision making. 0.7, that means 7 out of 10 times the score is right. It gives you the right answer, 7 out of 10 times. That is clinically meaningful. So you can start using that in practice, but a really good test, you want 0.8 area under the curve. That tells you an excellent test. So anytime you're reading a paper, they say area under the curve of this was better than that, but the numbers they're giving you are 0.65, 0.62, and 0.61. You know, all three tests are not very good. So what did this show? Area under the curve 0.63 and 0.64, which means they're really not very good at F2 to F4. But if you go to F3 and F4 and 11.4 kPa, how good is it? Here you can see area under the curve is 0.78 and 0.80. So it is better for F3 and F4 diagnosis. So to conclude, FIB4 and NAFL fibrosis score have excellent sensitivity at low threshold and high specificity. That means you can rule out disease. So at high thresholds, they're good to rule out significant hepatic fibrosis. And specificity and negative predictive value were also high. So what does this mean? Use FIB4 and NAFL fibrosis score. A, to rule out hepatic fibrosis. If the score is low, you're good. You can rule it out. If it's high, you're not so sure, send those patients for further testing to a hepatologist. And so these are exactly the same conclusions that you would have for a patient without HIV. A quick study here. So often on a liver biopsy, you see iron in the reticular endothelial system. The question is, does it mean this patient has advanced fibrosis? So ask yourself this question, I'll try and answer it. So is iron deposition hepatic reticular endothelial system? Okay. So this is again from the NASH network. So they looked at patients, almost 5,000 patients in this network. They excluded those who did not have iron studies or did not clearly have NAFLD, and ultimately they had about 1,600 patients who had iron and about 11 or 1,200 who did not have iron. Okay, so now let's look at this here. AST, those with the reticuloendothelial system iron high, ALT high, insulin high, insulin resistance score high. So iron and reticuloendothelial system telling you about insulin resistance. Look at platelet count. Those who had iron reticuloendothelial system, platelets decreased. And if you look at histology, looking at different characteristics here, so you can look at steatosis, ballooning, total inflammation, and finally making a diagnosis of NASH. If they had iron in the reticuloendothelial system, much more likely to have NASH. You can see this panel right down here, and much more likely to have advanced fibrosis. So what does this mean? In patients who have NASH, if they have iron in the reticuloendothelial system, they're much more likely to get hepatic fibrosis. So the clinical question which follows is, what if you reduce iron? Would you be able to decrease hepatic fibrosis? Next, again, a really nice study which I liked. So patients drink, and you tell them to stop drinking. But often they don't. The question here is, if you say, look, you have hepatic fibrosis, and I can show you have hepatic fibrosis, are you less likely to drink? So this is a study from the UK. So they had patients with usual care, which says stop drinking, or they had an intervention group. There are actually two interventions in this group. They shared video stories with them, which is what happens if you drink too much, and also did transient elastography in these patients. And what did the results show? In pink here is the intervention group. Blue is a standard of care group. So you can see in the intervention group, less drinking and less audit score. Audit is a score used to find out how much people are drinking, and it was lower. So once people know they have fibrosis, at least in the study, it's a small study, they are less likely to drink. Of course, if you give them stories about how patients had problems with alcohol, go in a little more detail, then again, they're less likely to drink. So just telling them to stop drinking probably doesn't work too well. Now, machine learning is important, and towards the end, I'll present some papers, not from this meeting, on machine learning, because I think it's really important for all of you to start thinking of machine learning for research, because I believe the software engineers in India are the best in the world, and I think they can help you do machine learning. So it's not just in hepatology, but in every field, consider machine learning, especially in endoscopy, because you've got huge numbers here. So the question here is, you have various scores. Does machine learning make it easier to detect advanced hepatic fibrosis? So this is the super learner. That's the machine learning method. It used 23 variables. You can see a large number of patients from different studies. So here's the difference between machine learning and the typical analysis that we do, the multivariable analysis. In all these analyses, we enter variables which we think are important to get the endpoint. Machine learning, the machine does not know what are important. It just picks numbers which look to be important. Those are numbers which we would never have thought about. You can see here it picked 23 variables, and from demographic, clinical, laboratory, and this was better. Okay, so that had the best. Interesting here is the SAFE score that was created by my colleague Ray Kim, who's now at Stanford. So SAFE is Stanford Advanced Fibrosis Estimator, and so that is also a good score. And the Stanford Advanced Fibrosis Estimator also uses diabetes and BMI. So Machine learning better than the traditional scores that were the APRI, FIP4 and all, and SAFE score is also a good score here. So that was trying to find out how much hepatic fibrosis and the implications of fibrosis. Next sets of papers we'll go over are on cirrhosis. So this is a VA retrospective study that was carried out. A lot of our patients with cirrhosis have mental illness, and we tend to treat the liver disease but not the mental illness. So the question here is, if you have mental illness and you treat it, do you really change mortality? So this is the work, David Kaplan is at UPenn, and he has been studying these veterans. He's got an amazing database. So he has been studying them for many years. So veterans are those who have been in the military previously. So they've got about 115,000 patients with cirrhosis whom they are following. They check whether they had mental illness, and the mental health disorder may be related to substance abuse, alcohol, other drugs, or mental health disorder not related to that, or no mental health disorder. So 3 groups. So generally, look here, middle panel, those without a mental health disorder, better survival than those with a mental health disorder. So if there's a mental health disorder, higher risk of mortality. And if you treat these, what happens? You can decrease mortality. And especially you can decrease mortality if the mental health is related to substance and alcohol use disorders. So I think it's important when you see a patient with alcohol-related cirrhosis, try and make sure that they see a specialist. Us telling them to stop drinking is probably not good enough. This study in a little more detail is rifaximin and lactulose more efficacious than lactulose alone. You might think, why do we need this paper? Why is it important? And so I'll go over that in detail because previous studies have not separated out those patients with ascites and without ascites. So this is again from the network that had the original registration study on rifaximin, and they showed that, at least they suggest that rifaximin plus lactulose is better than lactulose with or without ascites. I'm not convinced about this conclusion, but here they've tried to separate out ascites versus no. So rifaximin 550 twice daily reduced hepatic encephalopathy. And if you have ascites, then we know that's a higher risk for hepatic encephalopathy. So the studies that were done did not separate out those with ascites from those without ascites. And so the aim was to see whether rifaximin plus lactulose is better than lactulose alone, whether you have ascites or if you do not have. So this is a post hoc analysis. So they had multiple studies that were done. And at the end of the study, they looked at the information. So post hoc analysis is interesting, but the information is never very strong because post hoc analysis, the numbers are not enough. So the power is not enough to make strong conclusion. Okay, so they usually suggest and they give you a hypothesis which you should test in another study. So all patients with cirrhosis and overt hepatic encephalopathy, and at the end of the study, when they were analyzing the results, they looked at those with ascites and those without ascites. So the phase 3 studies are what I spoke about. Phase 4 is once it's marketed, once it goes into the community, you continue to collect data, and then that's called a phase 4 study. And so endpoints for the same: overt hepatic encephalopathy greater than 2, and time to first encephalopathy related hospitalization. So hospitalization typically means more severe and is a more important end. And they use hazard ratios, which we won't go into here. And they looked at adverse events. So look here, this is baseline ascites on the left and no baseline ascites. I think there's a bit of a problem here because if you have baseline ascites and patients have encephalopathy, that should give you a Child-Pugh score of 7. That straightway makes you B. If you have ascites and in an encephalopathy study, you shouldn't really be a child's A. But anyway, this is what they have said. And no baseline ascites, yes, I can buy that patients have child's A. So these are the results. In patients with ascites, rifaximin plus lactulose, better than lactulose alone. So here you have to treat 3 patients to prevent 1 breakthrough. Without ascites, you can see here, again, lactulose inferior to rifaximin plus lactulose. Your number needed to treat was 3. So that is, if you get overt hepatic encephalopathy, you treat 3 patients, you can save 1 overt hepatic encephalopathy. But what's considered a stronger or a harder endpoint is hospitalizations. So rifaximin plus lactulose, better than lactulose alone in preventing hospitalization in patients with ascites. But without ascites, you can see the p-value is 0.06 and number needed to treat is 15. So that is, you treat 15 patients, you'll say 1 hospitalization. That's generally not considered small enough number. So the number needed to treat is too big. And adverse events, little more in the rifaximin group than in the combination group. So to conclude, in patients with or without ascites at start of therapy, rifaximin and lactulose is more efficacious than lactulose alone to reduce occurrence of hepatic encephalopathy. I agree with that. The next line, I'm giving you the author's conclusion. They say also reduces the risk of HE-related hospitalizations, but I'm not sure the data on patients without ascites are that strong. With ascites, yes, I can believe that. And also, if you look at the numbers who are hospitalized, we know ascites is a risk factor for overt hepatic encephalopathy. So ascites, overt hepatic encephalopathy, use rifaximin and lactulose to reduce the risk of future hepatic encephalopathy episodes. Now, this is another study. Respiratory distress is common in patients who are hospitalized with cirrhosis. So what are the risk factors in here? And disclosure here, I'm a co-author of this multi-center study done in North America and now is being followed worldwide too. So albumin use and acute kidney injury are associated with respiratory distress. That's the conclusion of the study. So hospitalized patients will get multiple organ failure. They will get respiratory failure, either as part of multiple organ failure, as part of ACLR, or separately. And respiratory failure is common in those who are given albumin. So we know that from 2 previous studies. From the entire study, we know that those had higher respiratory failure if they were given albumin. And the confirmed study, which was a terlipressin study, again, those who were given albumin had higher respiratory failure rates. But this study, because terlipressin is not available in the United States, the question was, is albumin associated with a higher risk of respiratory failure in those who are not exposed? So the study was to determine what are the risk factors associated with respiratory failure, and prospectively enrolled patients, all non-elective hospitalizations. So if they were hospitalized for a procedure or elective surgery, they were not taken. Clear evidence of cirrhosis in adults, excluded those who were unable to provide consent or those who were terminally ill. So we have multiple sites, but we have restricted it to 50 per site just to make sure one site does not influence the results more than the other. Okay, so there's equitable distribution. Collected baseline data during the hospitalization. You can see all the factors that may influence acute kidney injury and respiratory failure. And we use the standard definition of respiratory failure, either intubation or SpO2 FiO2 ratio or PaO2 FiO2 ratios. and standard t-stats and non-parametric tests for statistical comparison. And towards the end, we tried to make a model, one with all acute kidney injury and one with only more advanced acute kidney injury. So I've highlighted, they were mostly men, 58% men, mostly had previous hospitalization, alcohol most common etiology. Hospitalizations were mostly liver related. Patients were sick, high MELD sodium scores, and the medications that could influence the outcomes we have included in here again. So let's look at how common are failures. Actually, failures are very common. So 1 in 5 develops respiratory failure, almost half develop acute kidney injury, and out of those, in half of them, it will be greater than stage 2. So at least 25% develop serious kidney problems after hospitalization. Bilirubin increases, encephalopathy increases, coagulation failure increases, and patients get shocked too. A third get transferred to the ICU. About 10% get transplanted. Death, this is 4% in this cohort, which is smaller than the national cohort in the US. In the US, the cohort is, the risk of death and hospitalization is 8%. Now let's look at this. These results are important. No respiratory failure in blue, respiratory failure in yellow. We'll go over the important differences. Those who have ascites more likely to develop respiratory failure. And if they have infection previously, more likely to develop respiratory failure. On admission, higher MELD associated with respiratory failure. During hospitalization, those who develop kidney injury more likely to develop respiratory failure, and those given albumin, again, more likely to develop respiratory failure. The reasons for hospitalization were really not that much difference between the groups who develop respiratory failure and no respiratory failure, except for the presence of AKI and respiratory failure. So you can see there's a little bias towards respiratory failure here. So outcomes between the groups, once you develop respiratory failure, you tend to have multiple additional problems. If you get respiratory failure, get encephalopathy after that, liver failure, and shock, ICU transfer, mortality. So respiratory failure is a really bad sign in patients with cirrhosis. Now, if you look at the albumin in detail, there are clear evidence-based indications for albumin, that's SPP, acute kidney injury, and large volume paracentesis. Physicians often use albumin for other reasons which are not clearly indicated, infections other than SPP, hyponatremia, or edema. And so 62% received albumin, more AKI in patients who received albumin, and higher the albumin, more likely the respiratory failure. And you can see that about 40% only were for evidence-based reasons. The others were not for evidence-based reasons. Be very careful when you're using albumin. So to conclude, almost a fifth of patients develop respiratory failure. Respiratory failure is higher in those who are sicker and those who have acute kidney injury. And respiratory failure typically can also be followed by worsening of kidney injury and other organ failures. Finally, there's a dose response curve, so be careful in how much albumin you use in these patients and monitor them very carefully when you give them albumin. Quick, this is more global. Is the etiology of cirrhosis changing? This is an analysis from Singapore looking at the global burden of disease study. And what we know already is cirrhosis higher in males than in females. So that is not new. What is new here is to show that when it comes to NASH cirrhosis, there's really no difference between men and women. women. So that's the message of this study. Again, question is, patient has HCV-related cirrhosis. You treat, and HCV has disappeared. Is it cost-effective to continue to monitor them for HCC? So that is the basis for this study. So large number of patients studied. We don't have the ability to go over details in here, but let me just give you conclusions of this study. Once patients have sustained virological response, the risk of hepatocellular carcinoma is 1.5% per year. That is the threshold for cost effectiveness. So it is cost effective. Continue to screen them for hepatocellular carcinoma even after they've cleared the virus. And those with more advanced hepatic fibrosis are more at risk of developing hepatocellular carcinoma than those who are not. Not entirely new, but confirmatory of previous studies. Now, this is again important because I think atezolizumab and bevacizumab are now available in India. So whenever the drug company does a study, they select patients who will respond the best and are least likely to develop complications. Because if you have complications in the study, then the drug cannot come out into the market. So drug companies are extremely careful about that. But then once the drug is approved, physicians will use it for every patient, not just the type of patient that was included in the study. So what does this study show? This study shows that if you have complications of liver disease, ascites, encephalopathy, low albumin, it won't do well. So that is the conclusion of the study. So in general, I think all drugs for HCC, Child-Pugh class A, that group do well. B and C, the outcomes are not that good. So A, they don't do well. B, they have side effects of treatment. And C, there's a cost consideration here too. So be careful in exactly whom you treat for HCC, especially if they have more advanced liver disease. Another cirrhosis paper. So more and more people who are obese are being transplanted. The question is, what is the limit? How high do you go up? So this is a study looking at the super obese, BMI greater than 50. Are those risks higher than 30 to 39 or 40 to 49? Try and answer the question yourself, and then I'll give you the data. So not many patients, 113 super obese. And remember, when you select a super obese, it means these were the best possible super obese patients that were selected, not just any super obese patients. So 113 were selected, and they were matched here, and you can see the results here. BMI 30 to 39, 40 to 49, greater than 50. So higher MELD score and more comorbidities in the BMI greater than 50 group. And results, this is the one which shows you graft survival. So graft survival in patients who were super obese here, worse than those whose BMI was below 50. And then if you look at patient survival, again, worse. So at least this would suggest that greater than 50 either don't transplant or we do some. So when we do a transplant, we also do a gastric sleeve procedure at the same time. This is interesting. So there's heparin and warfarin, which is used for portal vein thrombosis. Now we have directly acting oral anticoagulants. They're much easier to take. The question is, are they as safe and as good as heparin or warfarin? Again, ask yourself this question. So this is a meta-analysis, systematic review and meta-analysis. 9 studies, 211 patients, are not huge number of patients have been. So what did this study show? DOACs are safe, they're effective, but they're not great. Problem is 17% have a bleeding risk and 25% have treatment failure rate, which is also not that much different from warfarin and heparin. So cannot clearly say that DOACs should be used in all patients with portal vein thrombosis. I personally like to use warfarin in these patients. Now some miscellaneous topics. So you may see a patient who you think is drinking, but they say no, they're not drinking. Or you have an obese patient who drinks a little, but you're not sure whether the liver disease is related to obesity or it's related to alcohol. So can you find out? Our group, we're doing some studies on microvesicles, and circulating microvesicles can suggest you this is alcohol. Here, this group from Boston looked at mitochondrial DNA. So it looks like those who have liver injury related to alcohol will have circulating mitochondrial DNA. So if you can pick this up, or if there's a test for that, maybe that can be used to diagnose alcohol-related hepatitis. This is very preliminary here, but I thought it was interesting. This was, again, a very interesting study. This is from Taiwan. So they looked at 50 controls and 50 patients with HCC. So they have an animal model which develops hepatocellular carcinoma. When they gave this animal model with hepatocellular carcinoma stool from controls without HCC and compared them with animals given stool on patients who had HCC, the tumors in patients who had HCC who were given stool from patients with HCC were actually much larger. There's more growth. So it looks like if you don't have HCC, your stool actually prevents progression of HCC. So again, this is important, and they found specific bacteria associated with them. I do not know how to pronounce most of these, so I won't indicate, but there were 4 that they thought were important. So this I thought was interesting, and these are the pictures showing you tumors, those mice without HCC microbiome and those with HCC microbiome. So finally, again, I'm trying to make a case that you should do more machine learning studies. I'm giving you simple abstracts that were presented at other meetings, and 2 of them are from our group. So patients with cirrhosis, we know, have cardiac problems. They have RR intervals as prolonged, QTc prolongation. So they're distinct EKG changes. So we looked at 5,200 patients with cirrhosis and compared the ECG with 20,000 controls and came up with a model, which I'm going to show you a little more detail in the next. And we found that it was really good. So you just take an ECG, it'll tell you patient has cirrhosis or doesn't have cirrhosis. And it can also tell you how advanced the cirrhosis is. So a little more detail. So based on that, we had the ACE score, which is called the Artificial Intelligence Cirrhosis Estimator score, from 0 to 1. And you see area under the curve was 0.9, which means it's very good. But more interesting is look at the score compared with the MELD. As the patient's MELD score went up, the score went up. And then when they were transplanted, within a year, the score came back to normal. So you can automatically read out just from the ECG. So within our system, when you have an ECG, you can click on it and it'll tell you the probability that the patient has cirrhosis and whether the cirrhosis is advanced or not. So such a cheap test. ECG is available worldwide, far cheaper than FibroScan or anything else. So EKG may be a simple modality. The other thing is always difficult to differentiate on a liver biopsy. Is this alcohol related or non-alcohol related? So this is again from our group. We use digital image analysis and again, machine learning. And we actually think it's really quite good. It can separate the two and we had patients whom we clearly knew were drinking and those whom we clearly knew were not drinking. How correct we were? I mean, that's the study that was done. So we think in the future when we do a biopsy with digital image analysis, we can differentiate alcohol steatohepatitis from non-alcohol related steatohepatitis. And finally, in hepatology 2 months ago, this is machine learning compared to non-invasive tests. So 1,300 patients had liver biopsy, elastography, and laboratory testing. Again, they did machine learning, and you can see here, machine learning was better than all other tests. Okay, so hopefully next year you have some machine learning abstracts. So take-home messages. So I'll summarize all the abstracts that we had. FIB4 and NAFL fibrosis score can identify F2F4 fibrosis in patients with HIV and NAFL. If you have reticular endothelial system iron, increased risk of hepatic fibrosis. If patients know they have hepatic fibrosis, maybe they'll drink less. Machine learning models are better than traditional non-invasive testing for NAFL. Treat mental illness and cirrhosis that has survival benefits. Rifaximin and lactulose if patient has ascites. If patient does not have ascites, you can manage with lactulose alone, I think. Use albumin when patients have acute kidney injury very cautiously because they have increased respiratory failure risk. NASH cirrhosis now is increasing equally in men and women. HCC monitoring in HCV cirrhosis after sustained virological response is cost effective. What we call AB, atezolizumab and bevacizumab. Be careful in patients who are child B and class C. Liver transplantation, BMI greater than 50, try and avoid. DOACs, you may use them, but they're not really superior. Warn patients about side effects and lack of response. Mitochondrial DNA might identify alcohol-associated hepatitis. There is a specific fecal microbiome signature with HCC. And I think AI technology will be increasingly important in the future. And please, a request, I think I'd like to see more presentations from India at the next ASLD. I think in November, we have got very good representation from India at DDW, not so good. And please, some more studies on machine learning. Thank you.
Thank you very much, Dr. Patrick, for letting us know the abstracts which have been discussed. I believe in the next 10 minutes you have to leave, isn't it? So the question which I have is that in the respiratory distress, you don't have any information about the cardiac at all. Underlying cardiac status between them. We know that the other cirrhotics have got a heart failures and then other comorbidities. And is it that those who have got an underlying cardiac issues will have a more respiratory? That's understandable.
Yeah, so the question is, what was the underlying cardiac disease in these patients? So you know cirrhotic cardiomyopathy is more common than we recognize, but these are patients who are just taken from hospitals. Did some of them have underlying cardiac problems? Certainly. And I think if you have an underlying cardiac problem, and we'll go back to terlipressin, and if you use a vasoconstrictor like that, all that increases the risk. Yeah, maybe they had cardiac problems. We don't know.
Any one of you can ask, and because next 10 minutes, he has to leave, then we can continue the discussion within ourselves.
Dr. Kamath, actually, I used to ask you about that albumin story. What is the role of IVC measurement before giving albumin in these very critically ill patients? Because once they come, we always look at creatinine and sometimes start as maybe these are the patients of HRSAKI, top diuretic, wish to actually increase the hydration, and sometimes we'll depend on the IVC measurement before giving albumin and possibly a echocardiogram. What's your impression on those signs?
Yeah, so the question is, what's the role of echocardiography, respiratory variation of the IVC with, yeah, so in ICUs, they are used. In ICUs where you resuscitate patients. But remember, in most albumin is given outside of ICUs. I think it becomes not very practical. If you have a ward with multiple patients getting albumin, you'll probably need a full-time echocardiographer just in that ward to measure all this. So in the intensive care unit where the intensive care people are trained to do this, yes. The message here is, yes, clearly echocardiography monitoring is good for fluid resuscitation, but typically has been used only in the ICUs and not elsewhere. The additional thing that you have to remember here is it's simple physiological. 5% albumin, let's say you're giving 100 grams as 5% albumin. You're giving that in saline, and that expands volume right away. So most often, while the albumin is going in and somebody is infusing it, someone is actually seeing the patient. So the volume expansion occurs in about 30 to 60 minutes with 5% albumin. When you give 25% albumin, it takes time. Fluid needs to come in there because the amount of saline given is less. So the maximum expansion of volume is in about 3 to 5 hours, and often there is no one there. You give the albumin and then you go away. And that's when the volume expansion takes place and they get respiratory failure. So especially when you give large volumes, monitor them very carefully. I think just looking at the patient is enough.
Yeah, what Dr. Konar is mentioning is that in ICUs, it's a standard practice to do POCU. There's a point of air ultrasound where see the Z lines and then even 2D echoes at the bedside is done. Once it is done, there's no question of giving albumin in these patients in general. But what you said that your patients are mostly outside, but the type of the patient which you described appeared like only in ICU. Okay, over to Dr. Mishra, please.
Morning, Patrick. Your paper on not your paper, basically. The paper on obesity and liver transplant outcomes, they were not matched. They had bad MELD scores, the liver functions were bad, creat was high. If you have a matched, two cohorts, then you can attribute it to obesity. I know obesity creates a problem, but they were not matched over here.
Yeah, I know, I agree. First, good to see you, SP. No, I agree. So there are only 113 patients in there. So they try to separate out the obesity. Once you try matching, it becomes even more difficult. But I agree, it's not a matched group. In general, you have to be very careful. I think it's difficult to get. The point here is, I think it's difficult to get a person with BMI greater than 50 with very little comorbidity. That's going to be difficult. So if you have a BMI greater than 50 and you have liver failure requiring a transplant, to think they may not have any other comorbidity. The point here is, the higher the BMI, more comorbidity you're going to
Here
have.
the MELD score was very high.
Correct. I think that's because of kidney dysfunction in these patients.
Dr. Shiv Prasad, please.
Morning, Patrick. Shiva here. I have two queries. One is the one in which you had mentioned about, informing the patients who are alcoholic about their fibrosis scores and seeing whether that impacted their drinking habits. And yes, it did help. But don't you think that once in that group, you have patients who have bad scores and those who have good scores. But then if you're going to take the effort to inform them that they have no fibrosis and they're fine otherwise, don't you think that would be an encouragement for them to continue drinking versus those who just have been given a blanket, stop drinking, it's not good for you kind of advice? So you are really, once you have a normal scores in terms of fibrosis and other things, it might end up being also an encouragement, so the patients feel reassured that they can continue. So that is one point. I was addressing the issue of the ECG in cirrhosis study, which you had presented. I think it was also published in ACG some time earlier. As far as I understand, the AI was black box AI, in the sense like you don't have an explanation about how the AI interpreted the ECGs or what parameters it used. So is it possible to do the same study with Trainable AI, whereby you at least know what parameters are being taken by the AI to understand, yes, what is it that is we are correlating with cirrhosis.
Yeah. Thanks, Shiva. Again, good to see you. A lot of my PGI friends here. So the first one, yes, so that's a small study, the alcohol use. I previously liked biopsies in patients with NAFL because I thought, if you tell them you've got advanced fibrosis, they'll try and lose weight. So the reason for the two interventions, if you remember, they had transient elastography, but they also had those video stories, from those who recovered. So the hope there is, yes, you don't have fibrosis, but a lot of other bad things can happen to you, family issues. So those two interventions probably are going to help. So if it's TE alone and nothing else, you're right. In fact, if you don't have TE, we'll say, wow, maybe I can drink even more than before. Yeah, I think that's reasonable. So the AI is important. Actually, I was a non-believer when we first started the study. I didn't think it would work. But when we looked at the preliminary results, the ECG, 95% of the time, gives you the machine gives you the correct age between 5 years. It'll tell you whether it's male or female 95% of the time correctly. Then I said, okay, this is really picking up something. So to find out explainable, you have to do what's called silencing. Silence the P wave, then C, R wave, all that. In general, the AI people tell you you can silence what you think is important. But there are a lot of other things the machine is looking at. So yes, it can be done. It's a lot of work and a lot of expense. And at the end of it, you'll say, let's still use it. It's an important question. We don't know what driving this. We don't know.
Is
Dr.
the obesity a contraindication for the liver transplantation? And what is the best time to do a bariatric surgery? Is it before liver transplantation, at the time of liver transplantation, or post liver transplantation?
So the question here is bariatric surgery and liver transplantation. So when we have patients who are heavy, they go through a program to try and lose weight. And then when we looked at our patients, those who had lost weight, then were transplanted, they actually put on weight post-transplant. So they could get through, but later there was a problem. But the identical group who did not lose weight, remember this is not randomization, who did not lose weight, at transplant, they had the liver transplant and the gastric sleeve. They didn't put on weight post-transplant. So generally what's done is the most important thing here is the liver transplant, in the procedure. So the bariatric surgeons, the liver surgeons will actually have mobilized most of everything. And once they know the anastomosis and everything is okay for the liver, so they'd have also mobilized the stomach, then the bariatric surgeons will come in and do the sleeve. But if the liver transplant surgery was too complicated, then we won't consider the sleeve. So it's done in the same procedure. The mobilization takes place early, but the actual sleeve is only once we know the liver is fine.
Okay, thank you very much. I know it's time for you, I think. The time given in the IST time, 6:45, they're given that you have to leave. Is it?
Yeah, unfortunately, I lost one of my colleagues, so I have to go for the funeral now. So, but anyway, so I'm sorry I had to leave early, but thank you, everyone. And if there are any questions, I can see 6 very knowledgeable people there who can answer all those questions. But thank you, Dr. Rao,
Thank you.
Arshad, Manat, and all the rest. And thanks, Nagi and Uday and Randir for inviting me.
Thank you from all of us. Thank you, Patrick. Let's get on to our business in the next 15 minutes. I think the three most important from these that for us to discuss the vaccine and lactose. Second is again some more discussion has to occur on this. Not quite convinced about the third thing is vaccine. Anybody can take it up and then participate. Related issues because our there they have given the no indications. Of course, we also give sometimes without any indication that happens. But in an is a standard practice in ICU to do for a POCO. There's a point of care ultrasound and to see whether IVC is filling or not, and 2D echo at the bedside, and then we usually don't have a problem with the over of filling. And in fact, we don't give that much of an albumin also. The albumin given is very high in this.
They give around 100 grams. But we give around very less actually. Probably one bottle that is around 20 grams. Probably the dose is different. I think that is making the difference.
No, we don't give that much. Maybe cost reason or something.
That's true, sir.
In fact, we are doing a study on this. Low dose albumin for similar condition as in the guidelines.
He is mentioning that Patrick is mentioning the percentage is also different, which makes the difference 5% and 25%. Because 5% takes quick time to expand the volume and they are more prone to get respiratory failure.
Anyhow, the message is that you have to be careful in giving the albumin in the patients who are in ICU.
I think the speed of giving it matters a lot.
Yeah, that's
if you
right.
give it because we have the resident there monitoring, the chances of having a response.
Dr. Rao, I think it all boils down to the dose that you give. In the Western countries, for example, in SBP, 1.5 grams on day 1 and 1 gram on day. So that amounts to more than 100 grams.
And also their weight is more. Average weight is very high.
And they recommend fast transfusion during LVPs, post LVPs. That means they say they give the 50% of the dose, that is 2 ml per minute. In those patients undergoing LVP, they say the rate is also, infusion is also more. This
So in AKI, albumin is very helpful too. It's a double-edged sword basically. The only thing is, like I said, you don't have to transfer it fast. Give it slow. And probably 20% is better than 5% because the volume is less. And after all, you have to monitor these patients. And these patients mostly are in ICU. Somebody is monitoring over there. So they will not get volume expansion so far. The molecular, the milliosmoles of the plasma goes up very fast because of the albumin. That creates the problem. And secondly, all these patients are terlipressin. You have without terlipressin, then what happens, nobody knows.
Not only albumin, sir, all the products like fresh frozen plasma, platelets, when we infuse, they are more prone to get Raleigh. That is also one reason for getting a respiratory failure in the ICUs.
Anyway, let us conclude this that you have to give safely the albumin, and most of our respiratory issues are infection related rather than overhydration related in relation to the albumin. That's very clear in our practice. And next thing is about the rifaximin and the lactose. Of course, even 2014 guidelines, ASLD, EASL guidelines say that rifaximin is an add-on. This one. Only thing which this particular paper has said that with and without ascites, they said that with ascites you have to be more careful, and then you appears to be that you have to give, if there is ascites, you have to give the combination right start away as a secondary purpose.
Only thing is, I think if there is a previous history of overt hepatic encephalopathy, then we have to give the other. Not only ascites, if there is a history of previous in secondary prophylaxis, recurrent HE, then obviously I think we have to give.
Yeah, that's what I said. The ASLD 2004, we have been doing it actually.
That's right.
The only difference between what we have been practicing and now is that they have clearly separated the ascites and then without ascites. Therefore, they said that it's almost a must kind of a thing, those with ascites. That's the message which I thought we got from.
Real world, I think if you look at a lot of hospitals at the second level, you will find every patient is on rifaximin, he LOLA as well. That is not really right practice.
Regarding this rifaximin, they are using it randomly to patients who had, so we say 2 episodes of encephalitis. Differentiation or setting, I don't know, because cost of rifaximin possibly.
Most of the patients will be they'll go on like continuing the rifaximin. Is there any time duration? I think cut off the rifaximin because it gives this much time, like 1 month or 2 months. Is there anything like?
But some say it is lifelong till transplant. I use it lifelong. For country. Tablets per month is 100 rupees.
Yeah, strong indication is a relapsing encephalopathy. Relapsing and persistent encephalopathy is a definite indication for rifaximin.
Or even lactulose is expensive. So I think, in fact, but if they have a mortality benefit, you have to continue. And why 1 year? It's absolutely safe. The only problem is the patient comes and sub antibiotic kitne din tak de rahe hain aap? He himself is worried about it. But you have to tell him that no, this is not just not getting inside your body. So it's very helpful. And probably we need long-term studies on rifaximin. Side effects are nil. And if it helps in the mortality, we should use it. Maybe the companies bring down the cost.
I think hepatologists have only few drugs. One of them is rifaximin. All other
But, sir, with ascites it is okay. With ascites it is okay. Without ascites, you give rifaximin for life is also not justified. One, the encephalopathy episode take care of by some medication. Just because maybe having some encephalopathy in future, cannot keep on giving rifaximin forever.
I think
the setting is important.
It is only the follow-up, when you're following the patients, how frequently is going into recurrent encephalopathy is a question. Suppose if the shunt or a BRT was required, that's an entirely different thing. In a very, very child age cirrhosis is getting a recurrent encephalopathy is a different thing. In advanced, whether B and C is getting it, the natural behavior when it's frequently coming, it is a too frequent, this one, then there is some point in adding the rifaximin. Otherwise, we've been giving almost like a standard practice. Every patient gets a lactulose, if not for this one, even for other constipation also. That's it.
Also helps in minimal hepatic encephalopathy. Driving skills improve, the accidents go down. So that you should also consider this.
Sir, what is the status of LOPA, L-ornithine phenylacetate? Are we able to get it? Because 2 years back it was presented in a hepatology conference. Still we didn't get the FDA approval for that.
But I think there was one trial from Rajiv Jalan's group. He showed that it is not beneficial. Because he was the person who initially started promoting it. It is not supposed to be. We have LOLA, which is.
Okay, I think the important thing which has been discussed is the DOCAS in cirrhosis of liver. What has been your standard practice? When do you start the DOACs? Yeah.
There's maximum experience in the world with older generation drugs, acetylcholine and warfarin. DOACs are new, first started in neurology, cardiology, and then, as Patrick said, we have so much of vast experience with warfarin and acetylcholine that I personally still need to use and monitor it. The cost is so, whereas with DOACs, it's expensive. As we showed, it really hasn't decreased the sense of both as other.
That was, I was wondering, why did they say safe and effective when 17% had a bleeding and 25% had a failure? And still they say that safe and effective. The flip side of is that, the INR is the most important thing and the labs are not standardized And that is the problem with the INRs, this one.
Dr. Rao, I think that we now having patients on the waiting list for transplant. Patients are often advised to undertake surgery. They have the transplant. I think there are different categories of robotics. Some of them, as far as the trial goes, there were trials giving oxaparin for but before transplant. There are many regarding different sets of
I think
robotics.
the two groups which I insist on the anticoagulation is, one is that, as you said rightly, those who are listed for the transplant and they are carefully followed because they have to treat them, give them a good portal vein to the transplant surgeon.
Yes.
The second is that whenever you are following these patients, even a very soft thrombus, which was not there in the earlier previous visit, and then now it has appeared, and especially if there are no collaterals, then there's a time to start, because we know that heavy decompensation occurs after the portal vein thrombosis. That's one of the things which is highly preventable cause of a decompensation, which we found in the
DOS doesn't require any monitoring. I think that's where we probably acetram and all those things need. Yeah, we have antibody for that also. Especially if you use dabigatran, we have antibody for that also.
We have been using DOACs. Not be in a position to it.
Do you regularly screen the patients with the atezolizumab bevacizumab for esophageal varices?
We do before.
Just because because it's been associated with the bleeding tendencies, and then it's mandatory to ban them before we.
Dr. Rao,
Yeah.
Acetylizumab, bevacizumab, then we need a word of caution. One, it's so expensive. It costs 3 to 4 lakhs per month. And if you have to give it for 6 months, they already spent 24 lakhs, which is as much as a transplant in some place. And again, as you have seen, trials are done on selected group of captive patients. When you translate it to real world patients, you really find no difference. 53% in the original I am Brave trial, and again the same thing when you have real world situation. So I think we have to be a little cautious with. And plus, as he showed, this is again coming back to the Okoda classification. Anybody who's got ascites, low albumin, bilirubin, the large tumor mass, does very poorly. And most of our patients who come to us are either in child B or child C. So we have to be very cautious and just giving it to these patients who are well compensated and perhaps only child C. And then it can actually, this low high cost can actually drive a patient to poverty. And as you know, 63 million people in this country are driven to poverty because of healthcare costs. We have to always bear that in.
Yeah, you have to be. Mithun, you have some experience with the drug.
So, we had published a real world did as some patients. So yes, they first event 7%, but we had a overall survival of around 21 months per child, and it translated to a progression-free survival of around 18 months. What was more important between, if I compare with the lenvatinib and this, if I take across, if I remove the affordability for the time being, is that we never see a regression that much with lenvatinib. We have 25% patients of complete regressions. 2 patients underwent transplant, though there was a gap. There was no rejection in this patient. Rejection always come post immunotherapy, transplant or not. Had a washout period in these patients. So as of now, I would still recommend trial A and B. C definitely 100% no at this point of time, considering the side effects and adverse profile. Regarding the varicose screening, they have done a follow-up data of the IM Brave study, showed that actually the risk of bleeding was different. Though in the original trial, they screened all patients for varicose and eradicated them.
I think we have come to end of this. Any of the last 2-minute questions or any comments from the audience, please? None. I thank all the panelists for active participation. Thank you very much. Over to Dr. Randeep, please.
Thank you for participating in today's 3 modules, and just to remind you that we have to be here again at 9:30 tomorrow, because we'll start in time and nobody will be waiting for you, so you have to come in time. So please check out from the hotel and come in time so that we can start in time and finish in time. And today you're all invited for dinner at 8 o'clock in Jade Hall in Sheraton Hotel, where you're staying. So we'll meet you there. And I sincerely thank all the panelists who have taken part in very active discussions. And of course, we are thankful to the international faculty who have put in a lot of effort to bring you all these important abstracts. Thank you very much.